Thank you very much. I'm now going to ask our new chairman of the Health Overview Scrutiny Committee, Councillor Andrew Gravels, if he'd like to just open the session. Thank you, Andrew.
Thank you, Joe, and thank you, everybody. So from me, good morning, everyone, and welcome to this meeting of the Gloucestershire Health Overview and Scrutiny Committee, usually shortened and referred to as HOSC. As HOSC. When I first came on the County Council, I had no idea what HOSC meant, and I soon quickly picked that up and found it a really useful and interesting committee. My name is Andrew Gravels. It was a privilege to be asked to chair this committee at the last meeting of the County Council.
You've lost your sound, Andrew, I think.
Muted.
Andrew, you are muted.
Just to reassure you, Joe, Simon's on his way round.
Andrew Clark is still on hers.
What now?
Can you hear us?
Yes.
Wonderful. We're back on track. Okay.
So,
thank you.
So, Councillor Andrews and Rob, can you hear me?
Yes.
Okay, I'll start again. So, sorry for that slight hiccup. So, good morning, everyone, and welcome to this meeting of the Gloucestershire Health Overview and Scrutiny Committee, usually shortened and referred to as HOSC. My name is Andrew Gravels, and it was a privilege to be asked to chair this committee at the last meeting of the County Council. This is our first meeting since the new council was elected on May the 6th, and I'd like to welcome everyone to our meeting today, especially those of you who are new members, have just been elected and are here for the first time this morning. Just a few more words from me. As chair, I'm keen to ensure three things during the time that I chair this meeting, with your help, please. Firstly, I see that it's important that this key committee is never used for political point scoring. Our important work here requires us to be objective and to put party politics to one side. There's no place or time for political point scoring here at this committee. Secondly, everyone, I'm keen that we set our own agenda for our work programme. We'll be looking at that later, and I welcome ideas which certainly come out of left field. And thirdly, and finally, with your help, I would like this to be a hard-working and good-natured committee, where robust questions are put in a non-confrontational way, and where they're answered in an easy-to-follow and complete way. We don't have to turn this committee into anything resembling Prime Minister's question time in order to do our work effectively. That's enough from me, but I hope that will set the tone for the time that I chair this committee. I'm really keen to make it a friendly but hard-working and useful committee for the entire population of Gloucestershire, with absolutely no politics. involved. I'm now going to hand over to Joe for some housekeeping, and then we'll go on to introductions from all members of the committee, most of whom are new, or some of whom are new, and then I'll invite the NHS staff to introduce themselves too. So over to you, Joe, for some housekeeping. Thank you.
Thank you. Sorry about the little technical hitch there. We are getting a little bit of interference. Can I just make sure that when you're not actually speaking, could you just make sure that your microphones are muted? If you could just check. We're getting some noise from one microphone, but if we could just check that you're muted. This is a member induction session. It's not actually a committee meeting. The first committee meeting of the committee will be on the 13th of July. So the aim of this session is really to prepare members, of which there's a significant amount of new members, so it's a new and exciting time going forward. We're preparing members in readiness for the first committee meeting on the 13th of July and for the remainder of the year. Oh, excuse me, I think there may be somebody who's not muted. Can you just please check that you are muted? There's some noise in the background. Okay. We've got a number of presentations for you today. We've also got, later in the meeting, Sarah Scott, who is our Executive Director of Adult Social Care and Public Health, joining us. Sarah, during the past year, has frequently attended HOS meetings from a COVID-related perspective to update members on COVID and the response to COVID, the impact of COVID. It's been very useful and very informative. We're hopeful that Sarah, who's got a very busy morning this morning, will join us about midday. So this is for members to ask any questions relating to COVID. Sarah is the lead officer for the Adult Social Care and Communities Scrutiny Committee. There's definite links between those two committees, so from time to time Sarah will join us. A couple of housekeeping just arrangements. As I said, please mute your microphone when I'm speaking, and if you look at the bottom of your screens you should see a smiley face symbol, which is the symbol to press if you're wanting to speak, to raise your hand. If you've raised your hand and then you've spoken, please, if you could lower your hand. So that's just really the way to attract my attention later in the meeting if you want to ask any questions. I hope you can all still hear me. There's lots of sort of flashing symbols to say that some of you might be struggling with broadband, but hopefully you're still receiving this communication. I'm now going to refer you back to Councillor Gravels to take us through the agenda. Thank you.
Okay, thanks, Joe. That's really helpful and very useful. So can I now invite members of the committee to tell us who they are and where they're from. I don't mind in which order we go. So who's going to volunteer first? Maybe it's unfair, Councillor Andrews, for me to pick on somebody, but I've just noticed your surname obviously begins with A, so to get things moving, can we invite you please just to remind us and tell us for new members who you are, where you're from, and anything else that you see relevant to your work on this committee. Then everybody will have a pattern to follow. Okay, thanks Councillor.
Thank you very much. Councillor Stephen Andrews, Councillor with Cotswold District Council and one of the district representatives on this committee. My background is that I have been a member of this committee previously, including when it was called the Healthcare Overview Scrutiny Committee, and will no doubt bump into the overlap that does occur with care and public health, as Joe has already mentioned, going forward. Last year, I was subbing for another member of the District Council as the full co-opted member for Cotswold District. So I've kept in touch with the developments that have occurred, and in fact attended the last meeting of the old HOSC. My background includes being a volunteer with the ambulance service as a community first responder. So I also get to see not just the policy end, but the delivery end of health services. I'm a member of my local surgery patient participation group as well, which gives me another view on primary care. And so I have an interest in primary and urgent care in particular, but that inevitably feeds across into the rest of the health area. I've probably said more than enough, so I'll hand over to whoever you want next.
Yeah, thank you, Councillor. That was really interesting and helpful background. Just one question from me. Your background picture looks really lovely and pictured and beautiful. Do you want to give it a plug? Undoubtedly, it's somewhere lovely in the Cotswolds.
It's Lechlade, which is part of my ward.
Oh, you've got a beautiful area. I know that area pretty well. Nice day out by the river. Okay, so who's volunteering to go next, please?
Would it help if I go through the list? I'll just check who's available. Councillor David Brown, have we got you available to just give a short introduction to yourself?
Yes, thank you, Joe. David Brown, I'm County Councillor for Barnwood and Hucklecote in Gloucester, a neighbour of Andrews.
Yeah. Okay.
I have been on this committee before, but that was some years ago. So I'm really looking forward to getting back into it. I am a chair of my local surgeries patient participation group, and we work together well with the surgery. We've continued our Zoom meetings, and we're looking actually to try and roll out some more AEDs for the community. So that's one aspect that we're looking at, making them available 24 hours a day via secure cabinets. So yeah, I'm really looking forward to being on this committee, and good to see you all this morning.
That's great.
Thank you.
Linda Cohen, do we have Linda available to just give a short introduction? Are you there, Linda?
Yes, I am. Good morning.
Lovely.
I'm Linda Cohen. I'm the new county councillor for Wootton and Berkeley Vale. So obviously little previous experience, but I run a community interest company called Read With Me, and we hear some of the most vulnerable children in Gloucester read. So I see firsthand the healthcare and some of the impacts on some of our most vulnerable children. So I have a particular interest in coming to this committee and looking at what we can do to help that particular group, because there are huge challenges to make sure that they enjoy the same sort of healthy outcomes as their contemporaries.
Excellent. Councillor David Drew, is David available to just give a short introduction, David?
I'm there. Hello, Andrew.
David.
I'm David Drew. I'm the County Councillor for Stroud Central. I've been a member of HOSC before, and I've done a few other things, as some of you may know.
Thank you. Councillor Stefan Fifield. I've got the Stefan right this time, Stefan, not the Stephen.
Thank you, Jo.
Hello.
That's okay. Hi, everyone. Yes, I'm Stefan from Pittville and Presbury, so nicely nestled between Cheltenham and Tewkesbury. I am John Payne's successor. I'm newly elected both at county and borough, so quite new to all this. My background is I'm a management consultant, particularly interested in IT transformation, so I suppose I'll be bringing that sort of perspective to the table. And naturally, from Cheltenham, healthcare provision has been a bit of a political matter here recently, so I will have a keen interest in that. But as Andrew suggested, the chair suggested, in no way will I be political. Thank you.
Thank you. Councillor Stephen Hurst. Now, Stephen, you've been on the committee before, but would you like to just introduce yourself to the rest of the committee? Are you there, Stephen?
That's better, isn't it? That's much better for me. Good morning, everybody. My name's Stephen Hurst, and I'm a county councillor representing the Tetbury division of the county council. As Joe said, this is my second innings on HOSC. It really is a very important and valuable committee for the residents of Gloucestershire. I'm interested in organisational sciences, and that's a good challenge for the NHS, etc. in Gloucestershire also. Thank you.
Thank you. Councillor Jill Mosley, are you there, Jill? I don't know if Jill's...
I am, yes.
Yes, hello.
Hello, can you hear me?
We can.
Good. I'm newly elected from the division of Newent in the north of the Forest of Dean. I'm also a district and town councillor here as well. I suppose what I bring is some knowledge of the world of low vision. I suffer from I experience macular degeneration to a certain extent, although it doesn't affect my day-to-day life, because I've got the sort can be treated, and I'm a regular visitor to the eye clinic at Gloucestershire Royal Hospital, where there's excellent provision. I also help run a peer support group for the people with macular conditions in Gloucester, and I'm fairly well known, if you like, in the national scenario for the Macular Society. So that's really my only expertise, if you like, or knowledge that I bring. I'm anxious to learn about everything else. Thank you.
Thank you. I think we may have had apologies from Councillor Alan Priest. Alan, are you there? Oh, he is. Hello, Alan.
Yeah, good morning, Joe. Good morning, Andrew. Good morning, everyone.
Good morning.
Yeah, I represent Lydney in the Forest of Dean. I'm in my 4th term as a county councillor. I have subbed on HOSC in the past. I'm particularly interested in future South Forest health provisions. Thank you, everyone.
Thank you, Alan. Councillor Rob Vines. Are you there, Rob?
I am indeed. I'm Councillor Robert Vines. I'm the county councillor of Brockworth, and taking on board what Stephen Hurst said about his second innings, this is my third innings, I think, for HOSC.
Thank you, Rob. Right, we also have 6 co-opted members on the committee. We've heard from Councillor Stephen Andrews, who represents Cotswold District Council, and Councillor Dilys Barrell from Cheltenham Borough Council, a new council.
Yes, I'm here.
Hello, Dilys. Would you like to just give a short introduction?
Yes, I'm Dilys Barrell. I'm a borough councillor in Park Ward in Cheltenham. My background is in social work, and I've also worked as a volunteer with the chaplaincy both at Gloucester Royal and at Cheltenham General.
Thank you, Dilys. Councillor Helen Molyneux from the Forest of Dean District Council. Are you there, Helen?
Yes, Joe, thank you, I am.
Helen, are you all right to give us a little short introduction?
Yes, that's fine. I'm a district councillor from the Forest of Dean. Bit of typecasting, I think. I'm the older person's champion on the Forest of Dean Council. So my main interest is always older people, by which I mean anybody older than me. But there we are. Now then, my main interest, as I say, is older people. I did a lot of work with age concern before, unfortunately, they became very short of money and had to fold. My other main purpose is to check that the Forest of Dean is not left behind in any decisions that are made to do with health and care. We're right out on a limb, out at the bottom, and a long way from both Gloucester and Cheltenham. So I'm here to keep my eye on what's going to happen to the Forest of Dean. Thank you very much.
Thank you, Helen. Councillor Raymond, I think you prefer Ray, Ray Padilla from Gloucester City Council. Are you there, Ray?
Hello, can you hear me?
We can, loud and
Yeah.
clear.
So my name is Raymond. I'm a newly elected councillor in Gloucester City Council, and I'm one of the representatives to this August body. I'm currently working as a dermatology nurse in Gloucester Royal, and before that, I was a cardiology nurse and also a dialysis nurse. I'm particularly interested in diversity, trying to make the workplace and more diverse to cater to the growing number of the diverse composition of the body. And I'm also the chairman of the Filipino Association of Gloucestershire. Many of its members are working as nurses in the trust, and also the regional director of the Filipino Nurses Association in the UK. Thank you very much.
Thank you, Ray. Councillor Helen Fenton from Stroud District Council. Are you there, Helen?
Yes, hi there. Yes, I'm here. So yeah, my name's Helen Fenton. I'm representing Stroud District Council. I'm an elected councillor for Chelford Ward. Professionally, I work as a therapeutic counsellor. I do a lot of work with children and young people, both in schools and in private practice. So I have an interest in mental health. I'm also, one of my passions is improving women's reproductive and sexual health. So that might be an issue that I'd like to bring up at this committee. Thank you.
Thank you, Helen. And finally, Councillor Jill Smith from Tewkesbury Borough Council. Are you there, Jill?
Yes, I am. Good morning, everybody. This will be my third year, I think, coming up on the HOSC. I've got a background from working in the health service over 30 years, and I've worked in most of the physical facilities, although my main career was in mental health and learning disabilities. As you said, I'm co-opted for Tewkesbury, and I'm the elected member for the Hynham and Hallbridge ward. So I've generally got an interest in health and where it's going in the future.
Thank you, Jill. That's every member of the committee, all present and correct. So that's lovely to meet you all. And I'm just going to pass you back now to Councillor Gravels.
Thanks, everybody. That was really helpful, and thank you for telling us so much about you and setting the scene for our work together. That was really, really good. Just a little bit more about me. People were telling us how they've been a member of HOSC before. I've been a member of HOSC twice, maybe 3 times, and this is now the second time that I've chaired it. And the last time I chaired it, and I will try not to use that phrase too often, nobody likes to hear the last time I did it. The last time I chaired it, we tried to be quite innovative, and we weren't slow in using the powers that we have as a committee to refer things on to the Secretary of State. It's not something that we do lightly, but we involved the Independent Reconfiguration Panel, who looked at some of the services that the health authorities in Gloucestershire wanted to change, where we still had reservations. But I'm sure that we won't need to do that, and by having good and frank discussions, we will be able to work together with everybody across the trust and elected members in Gloucestershire. We did set up, Becky may want to talk about this later, what we called, I can't remember what the official technical term for the committee was, but we did set up what we called a no surprises group, so that when HOSC has to consider new items of work, that work has already been shared with a few elected members who are able to advise and pinpoint areas where there might be serious disagreements or more issues.
NHS reference group.
Okay, so it's not called, well, I said it's not technically called the No Surprises Group. It's being whispered, it's called the, what's it called again, Joe?
NHS reference group.
Oh, that sounds much more efficient. The NHS reference group. I call it the No Surprises Group. So we'll get by with working, whatever we call it, we'll get by working along that way. Final word from me before I invite our lead NHS staff to introduce themselves. My background is for 27 years I was a civil servant. I started off at GCHQ in Cheltenham. Didn't like that too much. Jumped ship and joined HMRC, and for 27 years I earned my living by asking lots of questions to lots of people in Gloucestershire. Please don't sigh when I tell you this, as a VAT inspector. So I give you warning that I do like asking questions. I stick to my guns until I get an that's not a threat. That's just the way I work, and hopefully we can all do that and ensure that we make best use of our membership of this committee. So that's enough from me. I'm now going to invite the lead NHS staff to introduce themselves, please, in a similar way. Thanks, everyone. So I'm not sure who wants to kick off, but just please go in any order, as long as we don't leave anyone out.
Becky, do you want to start the process?
Yeah, I'm happy to start. Thank you very much, Councillor Gravels, Andrew. I'm Becky Parish. I work for the NHS Clinical Commissioning Group in Gloucestershire. That's the organisation that has responsibility for buying NHS services on behalf of the people that live in Gloucestershire and make sure that they're good quality, safe, etc. I've been coming to the Overview and Scrutiny Committee for a very, very long time. I don't think I've missed very many committees since the millennium. So that'll give you a clue as to how many I've attended. It's lovely to see so many of you here. I recognise lots of faces, and there are also some new faces as well. I've made a few notes, and I've got some information to send to individuals based on some of the things that you said in your introduction. So I'm really looking forward to working with you. And I will hand over to my colleague Ellen Rule.
Thanks, Becky. Hopefully you can hear me okay. So hi, I'm Ellen Rule and I'm Director for Strategy and Transformation at the Clinical Commissioning Group in Gloucestershire, and also the Programme Director for our Integrated Care System. And I realise that might sound like a lot of slightly random words when I say that title, but hopefully we'll be able to explain more about the Integrated Care System and the different members of our system in terms of organisations and how we work together. And I'll be covering that when I go through my presentation later. I don't have quite the same length of time in HOSC committees in Gloucestershire as Becky. I'm not sure that anybody does, but I have worked on and off in Gloucestershire in the sort of nearly 2 decades that I've worked in the NHS. So I started my career in Gloucestershire in 2003. I had some time down in Bristol and working for NHS England, and then I've been here in Gloucestershire in this post for not that far short of about a decade. So I think between us, we're pretty much able to hopefully provide responses on things that you might want to ask us about. And if we don't have the answer, we'll always be able to go away and find it from somebody who does. So as Becky said, also looking forward to working with you all. And I'll hand over to the next person that I can see on my screen, who I recognise from my team, and that's Dr. Andrew Seymour.
Thanks very much, Becky. Hello, everyone. My name's Andy Seymour. I'm clinical chair of the CCG, Clinical Commissioning Group, and also a GP. I'm a GP in Gloucester City. I began as a partner at the old Heathfield Road Surgery in Gloucester in 1992. And then we merged into a new practice, the Aspen practice, several years ago. So I'm still there. But I'm only there 1 day a week. My main job is, the rest of the week, is chair of the CCG. And so I again look forward to continue working with those members who've worked for before and new members. And I will pass over to Ingrid, I can see on the screen.
Thank you, Andy. Thank you, Chair. I'm Ingrid Barker. Lovely to see you all. I'm the chair of Gloucestershire Health and Care NHS Foundation Trust. So we're the organisation that provides mental health, learning disability and physical community health services for the county. I've been around the HOSC table for a number of years now because I've been a chair of a trust for 10 of those. And previously I was a board member on the Primary Care Trust. So I do remember Andrew in his role as chair of the HOSC from those days as well. My background is as a social worker. I've worked mostly in mental health services. I've worked in third sector organisations, universities. I've also had some executive roles in the NHS when I was involved in re-providing the big institutions and providing community services instead. So that's a little bit about me. I can't see any of my colleagues on the
If,
screen,
if
but
it if
yes.
it helps, Ingrid, I got a list here, so it's
Oh,
not
fantastic.
this challenge of having to look on the screen. I'm going in no order. I'm just going to go down the list. Thank you, Ingrid. Is Angela there? Angela Potter.
Thank you, Joe. Yes, I'm here. Thank you. Hello, everybody. I'm Angela Potter. I'm Director of Strategy and Partnership for Gloucester Health and Care, the organisation Ingrid's just introduced. And I'm probably one of the newest health members to the committee. I've been involved for about the last 18 months, and I take the executive lead for the trust in relation to strategy and things that we bring to HOSC predominantly. By background, I do have a clinical background. I'm a nurse and I worked mainly within the urgent care setting outside of Gloucestershire. So look forward to working with everybody moving forward. Thank you.
Thank you, Angela. Deborah, are you there? Deborah Lee?
Yes, I am. I look like I've got a halo this morning. I don't know what that says. Thank you and welcome everybody that's new to the HOSC. I've been around many HOSCs in my career, and I have to say that I have found working with the Gloucestershire HOSC the most positive of all of those experiences. I'm the Chief Executive of Gloucestershire Hospitals NHS Trust, so we're the organisation that runs Cheltenham General and Gloucestershire Royal, and we're also responsible for a number of services that we deliver largely out of the estate that Ingrid and her team is responsible for, and that includes our maternity services at Stroud. So as I've said, I really do look forward to working with you all. I find HOSC rightly a challenging place. You're here to scrutinise what we're doing, but I've also felt incredibly supported by HOSC since I've been in the county, which is 5 years tomorrow.
Lovely, thank you. Mickey Griffith, are you there, Mickey?
Hi, good morning. My name is Mickey Griffith and I'm the Programme Director for Fit for the Future, which is just one of the programmes that has come before the HOSC over the last kind of 2 years or so, and there's a presentation today. Thank you.
Thank you. Paul Roberts?
Hello, colleagues. I'm Paul Roberts. I'm the Chief Executive of Gloucestershire Health and Care NHS Foundation Trust, which is the trust that Ingrid chairs, and obviously she just introduced herself a few minutes ago. I've been in the county for just over 3 years as Chief Executive, firstly of the predecessor organisations, and then when we merged to form Gloucestershire Health and Care in 2019 of the new trust. As Ingrid has said, our main services, we provide mental health services, services for people with a learning disability, community-based physical healthcare services, including we run the 7 community hospitals in the county. We run Wootton Lawn and Charlton Lane as inpatient, our largest inpatient mental health settings, Berkeley House as an inpatient learning disability setting, but most of our colleagues work in community teams and visiting people's homes or being based in local premises around the patch. So that's what we do.
Thank you.
Thank you, Paul. And I think that's on the list. Simon, are you there, Simon Lansley?
I am, yeah. Morning, everyone. My name's Simon Lansley, so I'm Director of Strategy and Transformation at the Acute Hospital, so part of Deb Lee's team. One of my main responsibilities is the clinical strategy for the Trust. So Fit for the Future has played a big part in my world over the last 3 years. And again, in those 3 years, I've enjoyed the inquisitive nature of HOSC, so I hope that continues. Thank you.
Thank you. I think that's everyone from our colleagues in the NHS. We have got our 3 representatives from Gloucestershire Health Watch, but I think we're going to let the 3 ladies, Helen, Nikki and Jill, introduce themselves when they come to their item, which is coming up very soon. We've also got 2 other representatives from Gloucestershire County Council, Councillor Carol Alloway-Martin, who is one of our cabinet members. Carol, did you want to introduce yourself to the committee? Carol, are you there, or you may not be online at the moment? Not a problem. I hope you can still hear me, everybody, that I'm not frozen. I'm hopefully not going to put our monitoring officer on the spot, Rob Ailiff. Rob, did you want to introduce yourself to the committee? I'm sure most people know who you are, but we don't want to leave you out.
Yes, thanks, Joe. My name's Rob Ailiff, and I'm the County Council's Monitoring Officer and Director of Policy Performance and Governance. And even though I've been with the County Council for nigh on 20 years now, this is only my second HOSC meeting, but I'm looking forward to working with you.
Thank you. The Chairman's just asked if I would introduce myself. So I'm Jo Moore, I'm from Democratic Services, and I'm here to support the Chairman and the committee with your work with health scrutiny. So I'm now going to pass you back to Andrew to take you through the agenda. Thank you.
Yeah, thank you, Joe. Ladies and gentlemen, that's taken some time, and I'm not going to apologise for that. It's been so useful to get to know everybody. I can't guarantee that we'll do it at the beginning of every HOSC subsequent to this meeting, but that's been a good icebreaker. I'm so grateful. Thank you. And Joe won't thank me for doing this, but I just want to thank Joe for all the prep that she's put in, getting this ready, getting this meeting ready for all of us. There's so much paperwork. The idea of setting this room up so that we can both be in the same room for this meeting has been so helpful. And so, Joe, you've set the bar very high, and thank you so much for doing that. Look forward to working with you as the new chair of this committee. Item 2, the appointment of vice chair. We're deferring that to the next meeting, if that's okay. That's probably the best way to deal with that, to get to know each other and take more time over that rather than try and do it today. The terms of reference, item 3, I'm going to hand back over to Joe to introduce these 2 items quite briefly, I think, Joe.
Very briefly,
yeah, cool. Yeah. Thank you. Back to you, Joe.
As Andrew said, I'm not going to elaborate or go into great detail on what scrutiny is. We've had training sessions on that, so I'm not going to present reams of paper. We're here today to receive an overview of information on the scope of what the HOSC committee is about. After the meeting, for members, I've got some very useful documents on regulations, on all sorts of information that you will find useful and that you can take time to read through to prepare yourself for the meeting in July. So I will send those documents through at any time. Myself, Rob Ailiff, the chairman, if you need to ask any questions on any matter, we're always available, we're always there, and if we're not able to answer the questions, we certainly will be able to point you in the right direction of somebody who would be able to do that. I've explained the links with adult social care. Scrutiny, HOSC committees, all scrutiny committees tend to meet 6 times a year. There's 6 meetings a year. There's no reason why we can't have additional meetings if there is a necessity to have an additional meeting. If there's matters that need more in-depth scrutiny, we can, at the chairman's request. If there are several members of the committee who wish to request a meeting, we can set up an additional meeting. It is suggested, and I think this will be considered as part of the work planning going forward, is that 2 of the committee meetings, one from the health scrutiny, one from adult social care, 2 dates, 2 of those meetings may be a joint meeting or can be a joint meeting where the 2 committees come together to consider matters of interest, of mutual interest, of shared interest. So that's a thought to pursue, to take forward, that out of the annual programme of work that we may combine the 2 committees to look at shared topics. Register of interests. For county councillors, Gloucestershire County Councillors, we have your register of interest forms. I just want to explain to our co-opted members, the members from the districts, that I, with your permission and with your help, will be emailing you after the meeting to seek a copy of your register of interests at your local authority, so that we've got those on record and that we have information on any maybe any conflict of interest that you might have with the committee. So after the meeting, I will be contacting those 6 members about having sight of your register of interest forms. It's just to have on file. The agenda, when we come to do the agenda for the 13th of July meeting, you may note that there is an item quite early on in the meeting where we have public representations, where members of the public are invited to submit a statement, a representation, can be a form of a question, that the committee have sight of before the meeting. Those statements, those points of view, those questions are shared with our NHS colleagues. We try to get a response circulated before the meeting. Usually at the chairman's invitation, the person making the representation is invited to give a little bit of an overview, a summary of what the statement or the representation is about at the meeting. And we try to, as a committee, take that forward, make note of it. If there's anything of importance or relevance that may need to be considered as part of the work programme, this is the process of inviting and engaging with members of the public so that they feel that they are involved in the work of the committee. I'm not going to go on any further. I'm going to send quite a great deal of information out after the meeting that you can digest, absorb, and please come back if you need to ask any questions. We will be looking at work planning later on in the session, and we'll hopefully come up with some ideas and thoughts for the work going forward. So I'm now going to refer back to Andrew.
Thank you, Jo, for that. It was interesting to hear you referring to our work programme, and I was really pleased to hear one of our new members from Chalford, I think it was, suggest an item that perhaps we could consider as a committee. I did say to Becky, when I was talking to her last week, that every time I said in a committee meeting, when I chaired HOSC before, I would donate a £5 to the Cheltenham Hospital's Focus charity. And I'm happy to do that. It's certainly a charity, the cancer charity, that I support wholeheartedly. So here's my first £5 coming up, Deborah Lee. When I chaired HOSC before, that's not one £5, that's just one £5, by the way, not 2. We used to move our committee meetings around the 6 districts from where we draw representatives. So in other words, we'd have one meeting in Gloucester, one meeting in Cheltenham, Forest, and so on. That's something that we can consider once we get out of virtual meetings, because it was good to see members of the public from those districts coming along to our meetings. And I remember at one of our meetings, David Drew turned up rather breathless, and I said, "You look a bit out of breath," and he said, "I went to Gloucester, I didn't realise it was in Cheltenham," or something like that, Dave. And he was on his bike, so he will certainly remember that we used to move around. So I think that's all I want to say.
Could I just come back in again? I just missed something off.
No, that's fine.
I
think that's all I want to say, Jo, on those issues. Unless anybody has any questions, any members have any questions that they wish to put to Jo or to myself or to Rob Ailiff or anyone else. If not, we'll move on. Any questions on what we've covered so far? Does it all make sense?
If I may, Chair.
Sure.
Stephen, yeah.
This is perhaps for Jo, really. Can you, or are you going to be circulating the MOU that exists between HOSC and CCG?
Indeed, yes. Yeah.
I was going to say, so that we can understand that context as well. Thank you.
Yeah, absolutely. I just think it's probably a lot to go through at the moment. I think that the presentations that you're going to get very shortly are going to touch on quite a few areas that you will find useful. But yes, we will be, and for new members, we'll be given an explanation on that. I just wanted to note very briefly, I mean, the work of health scrutiny in its simplest terms, and I've got a note here, is looks at the work of the NHS, the CCGs, healthcare trusts, and NHS England. And it basically the committee is to act as a critical friend in suggesting ways health-related services may be improved. So that is in its simplest terms. The terms of reference that you have in front of you are very clear. The regulations that we work to are the Local Authority Regulations 2013 in exercising the Council, Gloucestershire County Council's role in reviewing, scrutinising matters relating to the planning, provision and operation of health services for the county. There is a section here, and I'm just going to briefly touch on it, and I hope this is able to sort of make a little bit of sense going forward, is in commenting or making a recommendation in relation to any proposals that we may be asked to consider that involve substantial development or variation in services. Those recommendations, if the committee is minded that it feels that there is something that will not benefit the people of the county or will not make an improvement, that they want to scrutinise, that they want to look more in depth, we're often asked about the powers of the committee and the referral powers to the Secretary of State. I can qualify that. We can go into that into a little bit more detail. I don't think it's the right time here, but basically any referral powers to the Secretary of State, the committee must go through our full council. Basically, if the committee want to refer anything to the Secretary of State, then we refer to full council for a decision on that decision to refer to the Secretary of State. So I hope that does make a little bit of sense. Again, there's lots of information that I can provide on how a referral is made, what considerations need to be made, what evidence you need to provide. Hopefully we will never have to do this. It's not something that we hope to do, but going forward we will be providing some information a little bit more about the powers, the remit of the committee. So I'm not going to prolong the debate any longer. I'm going to refer you back to Andrew now.
No, that's really fine. Thank you, Joe, and thanks for highlighting that. And just very quickly from me, for all of us, just to remind us all that this is an induction session. For those people who are new members, this isn't the normal way which you will find HOSC working. It will be much more of a debate and much more interaction. So this session is, I keep repeating myself, is an induction session, bringing me, not just new members, but me, people like me who've been on the committee for a while previously or rejoined it, up to speed. It's been well thought out and it's an induction session. I can't stress that enough. Having said that, it's now over to Health Watch for part of our induction session. And I'm going to invite Helen Webb. I think, Helen, you're introducing this, or it might be you in conjunction with Nikki and Jill. Please help me out and take over. Thanks a lot.
Hi, actually I'm going to present just a brief overview, and then Helen and Jill will have an opportunity to join us for questions at the end. Okay. Joe, have you got the presentation?
I have. I'm just going to try and load it onto my screen now. Will that help?
Yeah. I'll make a start whilst Joe
should be with you now. Can you see the presentation Brilliant. On your screen? Yeah.
Thanks, Joe. So good morning, everyone. As I said, I'm Nikki Richardson and I'm the chair of Health Watch Gloucestershire. We're very pleased to have been invited here today as part of your induction to talk about our organisation and to answer any questions. So a brief presentation from me, and then Helen and Jill will join us if there are any questions. Helen is the manager of Health Watch Gloucestershire, and Jill Bridgman is our vice chair. If we could move on slides. I think we've missed one, Joe. So just to give a bit of context, Health Watch is the independent national champion for people who use health and social care services. It was established under the Health and Social Care Act 2012 to understand the needs, experiences and concerns of the people who use the services and speak out on their behalf. It exists on a national, which is Healthwatch England, and local level, and that means that we can understand what experiences look like for individuals at neighbourhood as well as at that national level. We have a number of functions. We provide information and signposting, we engage with the public, we carry out research and insight, and we monitor services. We have a number of statutory responsibilities, and just quickly listing those, we obtain views of local people about their needs and experiences of health and social care systems and make these views known to those involved in commissioning and scrutiny of the services. We make reports and recommendations about how those services could or should be improved. We provide and support the involvement of people in the monitoring, commissioning and provision of local health and social care services and options that are available to them. We make views and experiences of local people known to Healthwatch England, hopefully informing and shaping the national view. And we make recommendations to Healthwatch England to advise the CQC to carry out special reviews or investigations into areas of concern. Can you move the slide on? So Healthwatch Gloucestershire represents the view of people of Gloucestershire. The clue's in the title there. It's a small organisation commissioned by the local authority, and it's hosted by Evolving Communities, which is a community interest organisation. And that organisation manages and delivers independent health watch services here in Gloucestershire, but also in Dorset and Somerset. Our vision is simple. We want health and care that works for the people of Gloucestershire, and the people of Gloucestershire want health and social care that supports and helps them to stay well, to get the best out of services and manage any conditions that they face. Next slide, please. We're a small team, small but perfectly formed. The majority of our resource, including the board, is comprised from volunteers who give their time and enthusiasm and do a fantastic job. We have 5 staff team members, so a very small team, but they're incredibly enthusiastic. I can't tell you how hardworking they are, and their multi-skilling is remarkable. They really do an outstanding job. Local people are encouraged to identify areas of concern and bring these to our attention. Partnership working is key to our philosophy, and we work with other service user organisations to avoid duplication of effort. We make sure that by establishing relationships with key partners within the system, that we can have early conversations and be a critical friend. Commissioners also assist us in identifying any specific topics related to priorities. Throughout the past year in particular, we've developed our approach to become more agile as we've needed to adapt, as has everybody, to the changing needs and expectations of health and social care services during these real extraordinary and hopefully never to be repeated times. Next slide, please. We've used the feedback we've received during 2020-21 to develop a work plan, and these are 3 of the areas that we'll be looking at over the next 12 months. Of all our feedback during this period, care at home was the 4th most mentioned service, and we're going to be taking a much deeper look into the issues that have been raised. And before anybody asks in questions, the other 3 issues were GP services, dental services and COVID vaccines. And we carried out projects in these areas during the year, and we'll touch on those later. We're also going to be looking at the use of remote monitoring of health symptoms and working with the CCG on primary care's digital front door. And we are going to, as restrictions lift, re-engage with the public. We've had limited engagement with the public during this lockdown, and we've got a group of young listeners who'll be out and about to understand the experiences of young people, and we've got a new peer engagement project that's just been embarked upon and we'll be taking that forward. The next slide. So just to give a few examples of some of the work that's been carried out in the past year. So we carried out a deep dive into dental services because between July and September last year, over a quarter of all the inquiries we received were about urgent NHS dental care. We launched a mystery shopper style investigation, and from that we're able to make recommendations to commissioners that there needed to be far greater provision for people with urgent dental problems. We've met with dental providers recently and they've listened to our findings and are looking to make improvements. I think there's a clever thing now, Joe, that brings up the next example. 34% of our feedback last year related to experiences with GP practices, exacerbated by the challenges of delivering face-to-face care during the pandemic. And following a study into the ease of use and access to GPs, we recommended that GPs don't implement a one-size-fits-all approach to delivering care. And these findings have been shared with the CCG and with providers of the e-consult system to inform service improvement. And just to touch on the last project, we've looked at the experiences of people with mental health problems in accident and emergency departments. People in mental health crisis are unsure of where to go to get support and generally treat accident and emergency as a last resort. Service users recently have told us about the inconsistent approaches they experienced, and we shared our findings with both the hospital and health and care trusts, and they're now looking at ways to develop their approach to mental health services that will be on a par with physical health care. And that's a great piece of partnership working that's in progress at the moment. So I've rushed through that and I apologise, but does anybody have any questions?
If you just bear with me, I will just have a little look and see if we've got any questions coming through from any members. If you can, if you want to ask any questions at all, if you want to just raise hands using the device at the bottom of your screen. At the moment...
Sorry, just from me while we're waiting for somebody, are all your reports online? Are they easy to find online?
Yes, they are. If you go onto the Healthwatch Gloucestershire website, I say this with confidence, they're very easy to find on there.
And just another quick question from me. Do you give HOSC a heads up on the work that you're going to be doing so we avoid any duplication, for example? How does that work?
Helen, you might need to help me with this. I don't think we bring anything formally to HOSC, do we?
Not in my time, but then my time is literally just pre-pandemic, and then everything sort of went into freefall really, and it was all very pandemic focused. But I do think it's a good idea to be joined up, because actually to start, I was listening to what Joe was saying earlier about HOSC being the critical friend, and
sure.
That's our role too. And I think that because we all want the same thing, I do think that it makes sense to have that joined up approach, to understand what's coming over the horizon and to make sure that we're not duplicating. We make the best use of all the interested parties and the resources that we have. So we are a regular standing member of HOSC as well.
Sure.
Not as a councillor, but we're there every time, and we are quite happy to bring things to HOSC. If that's going to be helpful. So I think that, Andrew, I'm getting the sense that you want to kind of steer HOSC in a particular way. So I think that we'd be very open to having that discussion and seeing what we can achieve together, because I think together we'll be stronger than as individuals.
No, that's really helpful. Thank you so much. And it comes back to the point I was making earlier about working with our colleagues in the NHS. No surprises. So obviously we're not trying to influence your work or guide you. It's just to avoid any hiccups where we say, well, hang about, we're halfway through that piece of work. But I know you guys are a member of HOSC, so it's just good communications, isn't it? I just flagged that out. No criticism, obviously, or no intention to take over either, just to reassure everybody, obviously. Thanks, that's a really helpful answer.
Okay, we've got two councillors, Councillor Stephen Hurst and Dilys Barrell. Stephen, do you want to ask your question?
Thank you, Jo.
Hello.
Hello. Hello again. Thanks for a very interesting presentation, Nikki. I get the impression that could be well regarded as almost a professional scrutiny organisation. Would you regard that to be true yourself?
That's a good question, isn't it? I don't think I would use the word. I suppose it depends how you would define professional. I think our approach is very professional. I think the way that we deal with the information that comes from our scrutiny is very professional. But I think that the real benefit of Healthwatch is that it's represented by so many different people who come in a voluntary role, and some of those will be professionals and some of those will be very involved in the system, and at other times it will be people who have a passion about a particular issue and probably wouldn't view themselves as professional. So I think approach, absolutely professional. Composition of those carrying it out, probably very mixed, and I think real benefit from that mix.
And you have a very free, wide-ranging subject base, don't you? Whereas HOSC may not be as wide-ranging and free. We have a number of statutory, is that the right word? Statutory, if I can say it properly, statutory contributors who report to HOSC on their particular activities. So there are some differences, yes.
Helen, did you want to come in? I can see your hand raised. Did you want to come in on that question?
Oh, yes, please. So, well, I had a different question actually. Is this the right time?
Yeah, that's absolutely fine. Sorry. Yeah.
Yes. Hi, Nikki. I wondered whether, in the course of your work, you do anything like looking at the issues that, say, GP surgeries or hospitals have logged as complaints or through the PALS team, and whether that ever feeds into the decisions about where you put your focus of your work.
And we're not here to manage complaints on behalf of organisations. If people come to us to raise complaints, then we're very sure that they should be passed back to organisations to deal with. However, if we are, through the contact that we have with people, picking up on themes, then yes, we'll feed it into the system. It may then be why we do a particular piece of focused work. But there are two separate things that go on there. We've just been having some very helpful conversations with Andy Seymour about how we can develop better relationships with GP services so that we can have much more direct conversations. And we've been building up those relationships with the hospital and Health and Care Trust too, so that we haven't got to go in on somebody has raised this with us and this is a terrible issue and this is a complaint, but we can say this is what we're hearing in the system, so that we can take it forward at the earliest opportunity.
No, that sounds good. I was interested in that, looking for themes, because I think those are sometimes channels where patients will take their frustrations without necessarily knowing that Healthwatch exists. So it would be good to be looking for the themes in those channels, I think.
Yeah, absolutely. Themes it's definitely something that we, just to bore you with the detail, but we've introduced a new database last year, and it is much more able to help us do that. And of course, having access to the National Health Watch network as well, it gives us an opportunity to say, actually, this is something that is very particular here. On no, it's not. It's got a wider issue, and Health Watch England can help us take that forward at a different level.
Right.
Thank you.
Thank you. Sorry, Dilys Barrell, did you want to ask a question? I jumped there a little bit.
Yes, thanks very much. I wanted to say thank you for the presentation. Health Watch was not something that I've been aware of, and I think it would be good if it was better known, really, because it sounds as if you're doing some good stuff. I was just wondering how you decide on the topics that you're going to look at. I mean, can people make suggestions of areas that they think would be worth looking at, or how does it all happen? Thank you.
Thanks, and thanks. And thanks for that reminder, because something that we are looking at this year is to make that profile for Health Watch much more out there and much more known. I came into the role just over a year ago, and I was surprised how many of my close friends had no idea what Health Watch was about and that there was a local Health Watch. I'm going to ask Helen. Helen, do you want to just talk us briefly through how we identify our work streams?
Yes, we are, as Nikki has said, kind of small but perfectly formed. So we have to choose very carefully where we direct our attention and our resources, because as has been said, we have a huge remit and we can't be everywhere doing everything effectively. So we have to choose. It really comes back to two main things. First of all, is this what people are telling us? And we will go out and we will do straw polls on social media and other bits and pieces to try and scope out some issues. So it's first of all what are of concern to the public, because we are the public voice. Secondly, the question is, for us, will it make a difference? Will we have any impact? So there are some things that we know for one reason or another that we're not very likely to have an impact on, working with that closely with our partners across the health and care system. And the other thing that we also factor in is that horizon scanning. What's coming over the horizon? What do we need to make sure that we have that oversight of? So in addition to being the voice of the people, we're that independent oversight part. So for instance, in Fit for the Future, which you'll hear about later, we work together to make sure that we were satisfied that the public were able to have their say, and it was a genuinely participative process. So I think that there's no magic answer to that. It's always a balanced decision about what the public are saying, what we know the issues are, what's coming up, and where we can make a difference. And that sounds a bit vague, but I hope that it sort of answers in principle your question.
And just to add to that, the other important area that we try and look at, and particularly around the work of the other user organisations, is to try and avoid duplication, because we're all very, very small organisations, and if somebody's already looking at something, then that's not a work stream that we necessarily want to be involved with. We might assist in some way, or at some point we might take a theme from it, but we don't want to use very limited resources unwisely, and we don't want to bombard the public with the same questions but from different organisations. That's not useful. And I think the suggestion of making that connection with HOSC will give us another opportunity to ensure that we can try and avoid duplication wherever possible.
Yeah, that's good.
Okay, I can see two more questions. I think we just take the two on this item now and then move on. Councillor Raymond Padella, are you there? Did you want to ask a question?
Yes, for Nikki, please. I know that you've looked at GP practices, which form as basis for your accessing care through GP practices report to CCG. Just out of interest, do all GP practices display Health Watch information so everyone will know that you are around? Just like what we have in my workplace in Gloucester Royal, where Pulse information are just there for people to access. And, this is just to ensure that public can engage more and offer feedback. Thank you very much.
I'm going to jump in there, Ray, ahead of Nikki, because I'm more familiar with the detail of the operational work plan. And actually, as Nikki has said, it's our aim to be much more widely known. And it is on our work plan. We are collating places where we want our information to be, and what you've described covers exactly where we want to be. So not yet, but we will be during this year. That's part of our work planning for this year.
Thank you. Thank you, Ray. Councillor Stephen Hurst, your hand is raised. Did you want to ask another question?
Yes, please. And thanks for Nikki and Helen for raising a very important point. We're not just sitting our bums listening here. What I would like to ask you, do you believe that scrutiny should make a difference?
I'll start that, and I'm sure Helen will have a view too. Absolutely. Otherwise, I think the public would have every right to ask why we are forming committees and setting ourselves up as people who scrutinise. Yes, I do. And for Health Watch, it's about making sure that when we have scrutinised services or an area, that we make sure that we find somewhere to take the information that we have gleaned and talk to the people who provide those services and encourage and agree what's going to happen as a result of our scrutiny. And something that we're going to try and write into an ongoing work programme element is revisiting things that we've looked at to see that they landed, that change has occurred, and that we've made a difference. So we think it's very important, and we also think it's really important to make sure that we can demonstrate that we've made those differences. Helen, did you want to add anything?
I think you summed it up beautifully, Nikki. I couldn't say any more, really. That's, yeah, scrutiny, obviously, it's hugely important, essential.
Thank you. Are you fine with that, Stephen?
Yes.
Yeah, you're muted, Stephen. Sorry.
That's cool.
Okay, I'm going to now go back to Andrew. That's all the questions.
Should be to make a difference.
Yes, indeed. Thank you. Right, Councillor Gravels, do you want to take?
Yeah, that's been.
I think you've gone cold and frozen.
Who's frozen?
No, you're there. That's fine.
Can you hear me now, Stephen? Everybody?
Yes, thank you, Andrew.
So I was just saying that thanking our colleagues from Health Watch for a very clear and concise presentation. And I think that I'm always very keen on it was in easy to follow language. There wasn't a lot of jargon and abbreviations. Really, really grateful for that. I think as elected members, we can help you maybe by publicising Health Watch in the various newsletters and issues that we put out on social media. So if we haven't got them already, if Joe, looking across the table to Joe, could we get sort of social media addresses, Twitter, Facebook, and the website? And then when we publish anything on HOSC, we can refer to you. I'll certainly do that in my own ward. And David Brown, for example, who's a neighbour of mine, he represents the adjoining district. I think David used to our chair of the Gloucester Neighbourhood Watch. maybe you could plug Health Watch in that and raise another neighbour of mine. It looks as if we've got a little centre around my division here. That's purely by chance. Raise another neighbour across the road in Matson. Ray, if you could get that out in your area, just publicising the existence of Health Watch and what they do. I think that will be beneficial all round and help you guys to spread the word around Gloucestershire about what you do and your role, and maybe even later how we complement each other. Simply, there's no competition. But thanks for presenting in such a clear way. Really, really, really interesting, and you can tell by the questions it was well received. Thank you. Thank you so much. Thanks. So, turning over my agenda, we're on to the One Gloucestershire integrated care system, and I'm looking at my Chairman's idiot notes that Joe's given me, and it says that Mary Hatton is due to introduce that.
I'm not sure if Mary's actually here.
Okay.
Are you there, Mary, or
Becky? It's Ellen. I'm going to be doing the
Wonderful,
presentation
thank
today.
you.
Okay, Ellen, over to you. Thank you so much.
Thank you. And I think that somebody is kindly going to screen share the slides for me as well, which is marvellous, because then I don't have to drive and talk at the same time. Brilliant. He is, yeah. Thank you, Mickey. So I'm covering a slightly eclectic range of topics today, just in terms of things that we picked up from Andrew. I described it as the No Surprises group, but it's also our kind of planning and agenda setting group. Things that we picked up from that conversation that would be of interest in terms of relevance to the current agenda that we've been working on with HOSC over the last couple of years, and things that we felt that you as members would benefit from awareness raising on in this induction session. Obviously, this is not an exhaustive overview of the work of the health system, which, as I'm going to come on and describe, is actually quite a huge and diverse range of organisations, professionals, services and so on, working to deliver health and care services across our county. And as I mentioned in my introduction, we're always happy to provide information on other topics that are of interest to members, and with a bit little pre-planning, we can do that in future. So I'm going to provide an overview on, I don't know, are you managing there with the, yeah, there we are, perfect. Just wait for that to come up. So if we move on to that first slide, the topics that I'm going to cover today is just an introduction to the Gloucestershire integrated care system, and I'll say a little bit about what I mean by an integrated care system. We are going to provide an update on Fit for the Future, but that's going to come in a subsequent presentation. So in this introductory presentation, I'm going to provide a brief update on the Forest of Dean Community Hospital, because that's something we've been working on with HOSC over the last few years. I'll hand over to my colleague Andy Seymour, who will say a little bit about the progress we're making on the vaccination campaign, and I'll say a little bit about the COVID-19 situation in our county and sort of where we're at with that. And we're going to talk a little bit and share some reflections on how we work together with yourselves as FOSS members, and provide some useful links as well. So I hope that will provide some sort of useful background and context, and then obviously I'm happy to take any questions at the end. So moving on to the first slide. So in the NHS, we are a number of NHS organisations. So although obviously we all have that NHS badge over the door and that NHS banner, and we're all part of the NHS family, we are formed into different statutory organisations. And at the current time, and I will describe in a moment how this is changing, we are constituted as one clinical commissioning group for the whole of Gloucestershire. So that's Gloucestershire Clinical Commissioning Group. One acute hospital trust, which has 2 sites, so Cheltenham General and Gloucester Royal. We have also a mental health and community trust, which is Gloucestershire Health and Care, who deliver our mental health services, but also all of our community hospital services and community health services. We have 360 general practitioners who are in 74 practices. GP practices are effectively independent organisations that contract back to the NHS. And then we have those GP practices organised into 14 primary care networks and 6 integrated locality partnerships. I hope this is all making sense. It's quite different layers of organisation in one county. And actually, we are one of the simplest counties and ways of being organised in the country, in the NHS, given this single trust, single mental health and community partner and single CCG for Gloucestershire. There are, of course, also other primary care services. So there are dental providers, optometry providers and community pharmacists. At the moment, these are contracted directly to NHS England, although they are part of our sort of wider NHS family in the county. Taking those core Gloucestershire partners, however, that represents more than 11,000 NHS staff across our ICS organisations in Gloucestershire. So that's pretty huge in terms of workforce and major employers, obviously, in the county. And that we provide care to the whole population of Gloucestershire, so around 650,000 people. We also work obviously closely with the Police and Crime Commissioner and the district councils, the county council, and we have one ambulance services trust, although they do operate South West Ambulance Service across the South West region. So they provide services to Gloucestershire along with the counties across the South West region. You've got some stats here that I won't read out individually about our county, but perhaps the one I will just draw your attention to is around the increase in people in the 75 to 84-year-old age group, which is something to be celebrated in terms of the success of the NHS in supporting people to live longer, healthier lives, but also something around provides pressure in NHS services, given that this demographic tend to be higher users of NHS services, and also represents to some extent Gloucestershire being a retirement destination, of course, for some people as well. So the one thing I'll just say then before we move on to the next one is that, so this is how we're constituted at the moment. The current reforms that are going on in the NHS are to formalise an integrated care system as a statutory entity. So this means that Gloucestershire Clinical Commissioning Group will cease to be an organisation currently as things are planned by the 1st of April 2022, and will be effectively rolled into a formal statutory integrated care system, which will formalise at the moment what is a voluntary arrangement between partners to work together. In reality, on the ground, obviously that means the vast majority of staff who work in the clinical commissioning group will roll across, and the NHS has made an employment guarantee. But it does mean there's quite a bit of change coming in terms of how we organise ourselves within the integrated care system. So moving on to the next slide. Working together as health and care partners, we have an integrated care system vision and integrated care system values. So I imagine this wouldn't present any surprises to you, but our vision is about improving health and well-being by working better together, using the strengths of individuals, carers and local communities to transform and improve the quality of support and care we provide to all local people. And we work together around a set of values about working across boundaries between different professional groups and different organisations, and having a shared way of working across our quite complex system, as you can see from my previous slide. Okay, moving on to the next slide. Just to dwell briefly on governance, which I know is everyone's favourite topic, obviously. So, but it sort of falls, I guess, into the sort of boring but important category for you to understand how our different groups work together and how they work across with key council forums as well. So we have an integrated care system board, and we have membership of that from some elected members as well as senior council figures, and obviously the senior leadership team from the NHS and from representatives across primary care and so on. We have this two-way relationship with the statutory organisational boards and with the locality partnerships out in the different districts. And we have an executive who report into that board in the kind of usual way. and then a set of programme boards that sit underneath that. We also work across with the Health and Wellbeing Board, with the Leadership Gloucestershire Forum, with a non-executive director and lay member network, and a strategic stakeholder group that also involves wider partners such as district, county council members, but also in NHS England and clinical networks and slightly further afield as well. So we have a delegated accountability where, as I've mentioned, the integrated locality partnerships, where we bring together the primary care networks and relevant district councils and the voluntary sector into that. At the moment, that's a relatively limited delegation, but over time, we look for opportunities to delegate where working together at place can strengthen the response for local people. We also have a clinical council where we have multi-professional leads sitting around the table. So by that I mean nursing leadership, GP leadership, doctor leadership from the secondary care, from the hospitals, allied health professionals, pharmacists and so on, working together in a clinical council to influence across the integrated care system and ensure that clinical services are developing in the best way possible. And as I've mentioned, we work in close collaboration with the Health and Wellbeing Board and the Leadership Gloucestershire Forum, where, as you'll know, you have senior council leaders, but also Police and Crime Commissioner and so on. We work across that forum as well to bring a wider group of partners together. That also includes the LEP, of course, and thinking about the role of the NHS as an anchor institution in our county and a significant employer. So moving on, I'll talk a little bit about place. So we're organised broadly speaking around those district footprints. This is mentioning a little bit more this slide about that principle of anchor institutions. And we also work strongly in joint commissioning around with the Gloucestershire County Council around social care responsibilities, including commissioning jointly for people with disabilities, older people, services for children and families as well. And we have at this place level significant priorities that have been set by these integrated locality partnerships. So again, I won't read through all of this detail, but should you wish to look in a bit more detail at the priorities that have been set by the integrated locality partnership working in your place, then this is detailed here. So these are not saying that other priorities are not of interest to the ILP. These are just things they've chosen to prioritise in their current work programme. So you can see, for example, in the Cheltenham ILP here, the Integrated Locality Partnership, they're focusing on No Child Left Behind, OP Health and Wellbeing, Inspiring Families, Unstoppable, and what they're calling the Cheltenham Offer. And they have the primary care networks, which represent 16 GP practices. They link across with Cheltenham General Hospital and with the local leadership in that area through the district council. We're also particularly focusing on using our place-based approach to focus on health inequalities and actually wider inequalities, because we know that a significant contributor and driver of health outcome is the inequality and inequity that people experience in their lives, what we call the wider determinants of health, and the impact of psychosocial and other protective factors in people's communities. And so working to address those can actually have one of the most significant impacts on improving health and wellbeing. If we went back to that vision statement, our stated aim of the integrated care system. But moving on to the next slide.
Ellen,
yeah.
could I just chip in a sec, please? I gathered talking to Joe that these were all sent out, weren't they?
Yeah, they're
a few days ago, and they're
did you not want
online.
me to, sorry.
No, can we just take it that members have read them, if that's okay with you? And I stopped on this page because I've got some questions around health inequalities, but I just wondered if it might be a good place anyway, Ellen, to break and see if members have any questions on the points that you've highlighted so far, because I'm sure, like me, well, some of them, like me, may forget what they are. I certainly have some on inequalities in Gloucester, but can I invite members to put any questions that they have for you so far if any members are going to raise their hands. Just looking at
We've
the
got
screen.
Councillor Stephen Hurst and Councillor Stephen Andrews. Stephen Hurst, did you want to ask a question? Stephen, I think you muted.
I should have lowered my hand earlier. My apologies.
Oh, sorry. Okay, Councillor Stephen Andrews, would you want to ask a question?
Thank you very much. I've got two, actually, I'm afraid. I'll ask them both at the same time, if I may. One is, for a truly integrated care system, what is happening as far as cross-border issues are concerned? Certainly, there are areas where people get scooped up by the ambulance service, taken across the border to the most appropriate hospital, and then, of course, there's problems getting them back. And I just wonder how that is being considered going forward as part of that integrated care system. And my second question is, how are the place-based priorities established for each of the districts? Thank you.
Well, I think your cross-border question, I'm not evading the question, but I think it's quite a long, it could be quite a big topic in itself. Did you have any particular examples you were thinking of? Because there's two things I would group under cross-border. So there's the reciprocal arrangements we have in place with other English partner hospitals, so people's working on our boundaries. So if people were in Swindon Hospital or Bristol or whatever, those are very well established. We also have what I would probably determine as the cross-border issue, if you like, which is how we work across with Wales. Were you referring about how we work with other integrated care systems and hospitals that are around the edges of our county, or that specific cross-border Welsh-English point, Stephen? Sorry.
It wasn't the specific Welsh-English one. It was more to do with cross-border of your what a clinical the different clinical commissioning group areas at the moment within England.
Mm-hmm. Okay. Well, I mean, we do have arrangements in place to work across, to repatriate people across from, if that, because we have a reasonably significant, not a big number, comparative to other counties. We're amazingly self-contained, actually, with over 90% of people going to a secondary care hospital staying within the Gloucestershire boundary. But the ones that we do work regularly with would be Swindon, Bristol, Oxford, and to some extent looking north around Birmingham and so on. And we do have well-established protocols in place with those other hospitals. Depending on the service, sometimes those are informal clinical networks. So if they're cancer services, for example, we have some clinical networks where those services work in a kind of hub and spoke model, or say for trauma care, where we have a hub and spoke model as well. So that's an emergency model of care. That's not to say that, of course, that always is delivered perfectly every single time. And we do, of course, have conversations where we've had people, maybe that's difficult to find the right bed to move them back, or affecting a nursing home package when we need to reach across into hospitals in different areas. But we certainly do have arrangements and protocols to work with all those hospitals. And obviously that's something we're doing regularly, day in, day out, given the people who go across and the fact that we hold contracts with each of those hospitals for our patients as well.
That's lovely.
Okay,
are you fine with that, Stephen?
I was going to say thank you for that. I'm sure we'll explore some of the more detail as things progress in terms of how those links might improve by April next year with the integrated care system. But then on to the second point, which was the establishment of priorities for the place areas of the district.
Happy to pick that up, and if any other colleagues want to add anything to it. So I think when we go through any priority setting process, we always look first to the population and the profile of health need in that area. So we use an approach called population health management. So they will be, so what we do is we look at the health outcomes effectively and the burden of disease across that locality, and where we see perhaps, if you like, if you're looking at it like a school report, could do better. So maybe we're not seeing the outcomes we'd like to see in that particular area. We will identify that as a priority for improvement. And then those are the priorities that will be selected by that integrated locality partnership working together. They will also, of course, use their own knowledge of delivering care on the ground in that area, because as we mentioned, these are the GP practice leads working in that locality, the district councils, representatives of the hospital delivering care in that area, the community trust. So they will bring their own knowledge to the table, and also working with patient representatives as well at the local area. So I think some of that's outlined on the slide. As I said, they're using, that's where it says referencing using PHM, they mean population health management. There's always more things that we would like to select. So I think there's also a pragmatism that needs to come in about picking some things that you feel you can make a difference on and doing that improvement piece and then moving on the next year. But I think unless anyone wants to add anything, that's probably as much detail as I would provide at this point.
Could I just chip in there, Stephen? Is it okay if I chip in, please? Just picking up on your second question. I was looking at the place priorities for your area, and they seem, they seem fine, and you'll have your own views on them. I'm not going to comment on them. But looking at Gloucester, Ellen, who would have decided that the place priorities for Gloucester, where I am, are those two there? Social prescribing, I mean, that's key for everyone, I would have thought, and the development of a locality wellbeing hub. I'm not sure I know what a locality wellbeing hub is, and if we've got one, can you just sort of enlighten? There are 3 Gloucester members on here this morning. Thanks.
I have to confess, not being a member of the Gloucester Integrated Locality Partnership myself, or particularly close to that plan, that I would need to probably bring that back unless anyone else from our team felt they were able to offer that. I mean, I would agree that social prescribing is something that everybody is doing. And I think also the locality wellbeing hub is probably, in my view, a specific part of a wider prioritisation of health inequality in Gloucester City. So I think the broader way of, maybe that's not a particularly great way of describing it. I think what their priority is about addressing inequality, which is the biggest priority in Gloucester City, and that one aspect of that, maybe an early priority within that broader health inequalities plan, is to develop a locality wellbeing hub. But I'm afraid I don't have detail of what is intended with the locality wellbeing hub, but we could bring that back, I'm sure.
Sure, I think Angela Potter is trying to come in, is that right?
Yes.
Angela?
Oh, great. Oh, one actually.
So, sorry, just to add to what Ellen was saying, if I may, Chair, all of the locality partnerships used a lot of the population health data to look at where the most prevalence of need was in order to determine the priority work streams that they were going to take forward. And obviously within Gloucester City, the health inequalities and a number of the deprivation indices were what were driving potentially the solutions that were coming forward. And Gloucester City tends to be, because of its level of deprivation, one of the areas that we pilot quite a number of our things with across the county. So I'm more than confident that each of the ILPs would be happy to bring an update to HOSC in due course, and across them all, GHC is well represented, so we're happy. I'm happy to facilitate that moving forward as a supported action.
But I mean, I shouldn't hope this, but I'm just trying to understand, for the sake of the other Gloucester members, not just myself, what a locality wellbeing hub means, and do we have one?
I think most of the plans are still in transition because of COVID. So I think, as Ellen said, in terms of its exact configuration, in how it links out into the health and wellbeing offer that we commission across the county, along with the health and wellbeing and social prescribing link workers that are now embedded within the PCNs, it's probably something that we would be better bringing back as a definitive answer.
Yeah, Angela, before I bring Stephen back in, I'm really happy to follow that up with you offline. But also, I'll take the opportunity to copy Councillors David Brown and Ray Padilla in, who are also Gloucester members, if that's okay. Is that okay?
Yes. Thank you, Andrew. Yes, I would like that.
That's really fine. And Ray too, hopefully. My neighbour, well, you're both neighbours of mine, coincidentally. Stephen Andrews, you were trying to get back in before I take
Yes, it was, and it's perhaps to get Becky to comment, because I see a role here really for PPGs and the patient participation at PCN level, which doesn't seem to exist yet at the moment, certainly in the Cotswolds, to perhaps comment and actually help to develop these ideas from very much a patient perspective.
I'm happy to comment on that, and thanks, Stephen. Nice to see you. A new innovation actually for PPGs. Some of you may be aware that each GP practice has a patient participation group, which is a group of patients registered with the practice who take a particular interest in ensuring that patient views inform practice development, etc. We have a county-wide patient participation network where we gather together as many of the PPGs on a regular basis to talk about all sorts of different topics. And I think some of you here have attended those meetings in your other roles as members of PPGs. For the last meeting, Stephen, and I'm not sure if you were able to attend that one, we have started to host a locality session after the county-wide meeting has taken place, and we're going around each of the individual localities. We started with the oh gosh, memory's gone. I think it was the Gloucester PPGs, the last meeting. But we will be going around, and we are going to encourage them to meet together as PPGs from the GP practices that are within a particular area. So they will have that opportunity to talk about common themes that they're picking up on. Also triangulate that with perhaps what Healthwatch are hearing, and then feed that through and into the GP practices. So really good point, Stephen. We're just starting with that as the PCNs are starting to become more mature, and it's definitely an area for growth in the coming year.
Thank you.
Okay, thanks, Becky. Helen Molyneux, I think you were next. If you're still there, please.
Thank you very much.
Thank you.
Can you hear me? Yeah? Right. Councillor Andrews might be sorry that he raised the cross-border issue. That's me. Right, my ward is the Tiddenham ward in the Forest of Dean. And if you have a look at the map, we're the very last bit before you fall into the Bristol Channel. Some of my residents are registered with Welsh GPs, some with English GPs. So cross-border issues are frequently brought up. Now, with the opening of the new hospital for the Forest in Cinderford, the south of the Forest is still in a very difficult position. And I'm glad to see tomorrow that I'm going to join in the Zoom, which discusses the south of the Forest issues. We need good, strong links with English hospitals, for example, in Bristol, and in Wales, for example, in Newport, because that's where my residents go. I'd have to tell you, they can be in Bristol in 20 minutes, they can be in Newport in 20 minutes, they can be in Gloucester in an hour, if the roads are not too jammed. Now, Forest of Dean has, when we're talking about locality needs, the Forest of Dean has an ageing population. We have poor health, poor digital connection. All these would need to be addressed. And patient participation groups, are they going to exist in the Forest of Dean? And are there going to be participation groups between Welsh and English patients of the Welsh registered practices? Thank you. I'm sorry to throw a bomb into all this, but it is my bête noire, as they say. I have to look after the Forest of Dean. Thank you.
Okay, thanks,
No, well,
Helen. Who's going to answer that?
I'll start. I mean, I'm very glad, Helen, that you are looking after me, because I'm not quite in your Tittenham ward, but I am a cross-border patient. So thank you for having my interests at heart. I have one of those lovely GP practices that's actually in England, but a branch surgery of a Welsh practice. So it all gets terribly complicated. I was going to, a little bit later on in my slides, and happy obviously not to run through them all if that's taking too long, but I was going to give a bit of an update on the Forest of Dean Hospital and just confirm, as you've said already, Helen, actually, that we've got that workshop tomorrow, where we're going to be looking with around 30 people are coming to that workshop, some stakeholders such as yourself, and I think Councillor Priest, I think, is coming as well, and members of the public and other partners across the patch. So we're really looking forward to being able to get into these issues in a bit more detail and talk both about the offer that we do have and how we might want to be a bit more, what's the word, on the front foot at describing that and sharing that with people, as well as what we might need to continue to develop in the future. I mean, mentioning, as you did, the priorities for the forest of older people, you can see that one of their place priorities is the delivery of the complex care at home service, which is something that's been significantly invested in for across the county, but specifically in the Forest of Dean, which has been one of the earlier areas to go ahead with that. And that has felt like a really important priority for the forest, where you've got particularly older people with significant deprivation in some cases, living in a very dispersed community. So if they do need to go into hospital for their care, it's generally going to be further for them to travel, more difficult for their relatives to get there, and so on. So the complex care at home model, providing that support to them in their own home, has been something that community has really prioritised. I'm sure that there is somebody who knows better than me what happens with patient participation groups from cross-border practices. I feel if Becky doesn't know, we would be able to ask, I was about to say a chap who does, but actually it's a lady who does, my colleague Caroline, and come back with that response. But Becky, I don't know if you want to say anything about that specific point about PPGs from practices that work across that border zone.
Yeah, I can add a little bit, and Helen, I can find out more information for you if needs be. In Wales, they have a slightly different arrangement to in England. So as you'll recall, I mentioned each GP practice in England has a patient participation group. In Wales, the voice element of patient representation is managed through the Community Health Council. And we have a good relationship with the Community Health Council for the Aneurin and Bevan Health Board area. They've been involved with the recent pieces of work that we've done around the new community hospital for the Forest of Dean, for instance. What I don't know is whether or not the individual practices have arrangements for particular patients to meet together to feed into that health council. But I will find out for you, Helen, because apart from anything else, I'd like to know as well. So I'll pick that up as an action for me.
Okay,
Thank you very much.
Helen, well done. Thank you for your question, and Becky and Ellen, thanks for your answers. I am very conscious of time. I'm also very conscious of the fact that these slides were circulated a few days ago, and everybody's had time to look at them over the lovely weekend in the back garden. So I'm going to propose, Ellen, that we move on and we go to your summary pages, which are the last two, how you worked with HOSC and the website links, if that's okay, plus any other series.
That's fine.
Sorry?
Yeah, there's quite a lot there. So if I go to slide,
I was looking at
can't
the
see the
page
page
which begins
actually.
how NHS ICS
How
partners
we
work
work,
with
how
HOS.
NHS, yeah, I can
Is
see.
that okay?
Yeah, that's it, Mickey.
And, you know, I'm not rushing it because we've had these, you know, for quite some time. So, you know,
Oh,
I
I'm
think
happy to be rushed, Andrew. It's fine. I
is
won't
that
take
okay?
any offence at that.
And then
at
we'll
all.
invite
Rush me
members.
off on that.
Yeah, we'll invite members to come in with questions, Ellie. So, just summary of
Yeah.
those last 2 pages, please.
Sure. So, I mean, I think the first bit is probably pretty self-explanatory. So we attend HOSC, we provide regular reports, but we can also identify and schedule future agenda items. We try and we like to, obviously, I think like everybody coming to a public committee, to be able to be briefed what you would like us to bring information on so that we can prepare and make sure we've got the answer to the questions that you want us to cover. And we also have this memorandum of understanding that we've set up where we can agree between us when a proposal we want to make might constitute what is formally known as a substantial variation. So that is a significant change to a service where there may need to be a specific scrutiny role as set out in the statutory guidelines. So we've set up this MOU so that we can agree that and be clear from both sides when we're on a topic that does constitute a substantial variation. So at the moment, the things that would be subject to that would be, for example, the Fit for the Future programme or the Forest of Dean new hospital. So that's just something we've set in place so we can be clear how we are engaging on those specific topics, because the rules are slightly different, aren't they? And then I don't really need to talk about the last slide, but we've just provided for you some website links where we have just lots of information and also, like, you know, materials on our various projects and programs that were outlined in this presentation, but in a lot more depth. We've also got the Get Involved in Gloucestershire online participation community that may be of interest to some. And then there's our different organisational websites there as well. So I'll stop there.
Okay, Ellen, that's really helpful. And thank you and your colleagues for sending out the slides. I think it was last week, wasn't it? So we've had plenty of time to look at them. Did you want to say anything else on the new Forest of Dean Community Hospital development? Do you think you covered that off?
I don't think I particularly need to, but I think what people might be interested to know is that obviously we've confirmed the model of care and the single hospital, the sites being bought and so on and so forth, and the ground and site investigations have been incorporated. So the final kind of process part of that is the actual business case with the final configuration and building detail, which is what we're working up at the moment. And we expect to be able to submit for planning approval over the summer. So we will come back and obviously share that with HOSC when we've got that detail at that sort of final stage before we can move on to actually making this hospital a reality for the local community.
Okay, Ellen, that's really helpful. Thank you. Sorry, Dr. Seymour, you've indicating you'd like to speak, please.
Well, thank you. I just wondered, would members appreciate a few minutes update on the vaccination programme? That was in the middle of Ellen's slides. We kind of slightly skipped over that.
I'm sure we would. I'm slightly confused because I was understanding that Sarah Scott was speaking to that too.
I think Sarah Scott's going to give some data at the end of the session. A quick summary of the vaccination.
Yeah, Dr.
programme.
Seymour, please tell us what you've got. Thank you so much.
Yeah, happy to take you through that. And clearly, I've got quite a lot of detail if people want to dial down. But essentially, as you know, we've been running the programme throughout the county, a whole system effort from before Christmas. And as I say, it's been a great system-wide effort. So the Hospitals Trust started the vaccination programme, concentrating on mainly health and care workers. And then the PCNs, so that's the groups of practices working together across 10 sites across the county, have delivered the vast bulk of the vaccination programme since then. And also working collaboratively with Gloucester Health and Care Trust, who helped deliver some of the housebound vaccinations. And as you'll probably be aware, also there are some community pharmacies also delivering jabs across the county. So just to put things in context, we talk about cohorts through from 1 to 12. These are the cohorts we're trying to vaccinate across the whole county, and 1 to 12 would cover the whole of the adult population. And the initial drive was to cover cohorts 1 to 9, so that was anyone above the age of 50, anyone classified as clinically vulnerable, anyone who had chronic and serious significant illness, and all health and care and staff workers. So that was cohorts 1 to 9. And the importance of that group is that in the first wave of the pandemic, 99% of all hospitalizations and deaths occurred in that group. So that was the group we were really concentrating on getting vaccinated. And it's really pleasing to report that in this county, we've now got 88% of that group have had both vaccinations. So 88% of the groups 1 to 9 have had both vaccinations. So that's hugely encouraging. And then the other cohorts 10, 11 and 12 are going down through the ages. So the 40 to 50s, the 30 to 40s, and then the 18 to 30s. And we're currently working down in chronological order in terms of that age group. And we're just embarking on the 23-year-olds at the moment to get their first dose done. And we're also bringing forward the interval between the second doses of those certainly above 50. And we're now looking at bringing forward the over 40-year-old groups so that their interval reduces from 12 to 8 weeks. So again, we would hope to see more rapid double vaccination there. So in terms of overall vaccination across the county, 80% of adults have had at least one dose, and 61% of the whole county have had both vaccinations. So it's a really strong performance across the county. We're one of, if not even the best across the southwest and therefore across the country. So sterling work from all partners. And I must also mention and pay tribute to volunteers who have helped run these vaccination sites, both in terms of giving vaccinations, but also help manning and staffing. So a huge effort, greatly appreciated across the whole county. I think that's all I probably need to mention, but I'm happy to take any questions or comments. Thank you.
Andrew, Councillor Priest, please.
Sorry, I didn't catch that.
Alan, Andrew.
Oh. Alan, yeah, sorry. Go for it. Chairman of the County Council's respectful, sorry.
Yes, thank you. Thank you, Dr. Seymour. Just, have we actually got any percentages of people in the county who are actually refusing the vaccine? And is there any pattern on those who are refusing the vaccine? And are we trying to do anything specific to educate people on the importance of taking the vaccine?
Yes, thank you. It's a really good question or set of questions, and it's difficult because we make strenuous efforts to contact people and then recontact people if they don't engage, and we've had various messages, social media, letters, telephone calls. But we don't actually capture data of people who refused. We just capture data of people who have been who have come forward. So the assumption is that people who don't come forward have refused. But when I say we make every effort to contact, and there are a mixture of reasons, but we don't capture it formally. But anecdotally, it's usually about the requirements need to be educating people on terms of allaying some of the fears that they may have. We've also done quite a lot of work in terms of vaccine hesitancy, and I see Paul Roberts is on the call, and Paul may want to chip in on there because he's been leading that work about reaching some groups who are perhaps more traditionally harder to reach. Perhaps Paul, you might want to comment.
Yes, just briefly, Councillor. Yeah, so we've run something we've called a vaccine equity group from very early on in the vaccination programme, and our aim is to make sure that all different communities within the county get equitable use of the vaccine, and that involves lots of using publicity, social media, local community groups to speak directly. We've had people actually visiting things like barber shops in the middle of town to talk to people in certain communities in barber shops. We've gone into faith communities. We've recorded videos with people from different communities. We've also done things to try and make the vaccination more convenient for people that might refuse it, partly because they don't see it as convenient to their lifestyle. So we've been running outreach groups to go out into communities. For instance, we did a major push on vaccinating people who were homeless within the county. As an example of that, we're also working with the travelling Gypsy and Roma communities to make sure that they're vaccinated. We know that younger people are less likely to come forward to be vaccinated. Even gender a bit. Men are less likely to put themselves forward for vaccination. Ethnicity is an issue and deprivation is an issue. So we're looking at all of those things to try and just even up. The honest answer is, if you look nationally, people from Black African, Caribbean and Black British communities are less likely to be vaccinated than any other ethnic group. And that's true across the whole country. We've done pretty well in Gloucestershire, but that's still true in Gloucestershire too. So our figures reflect the national pattern, but as I think Andy said earlier, generally our figures are amongst the best in the country. So we've done pretty well on that agenda.
Thank you, Dr. Seymour. I'm Paul. That's reassuring, all the effort you're putting in. Thank you very much.
Okay, thanks, Chairman. Thanks, Dr. Seymour. David Drew. David.
Thank you, Andrew. I'm just interested in how we capture those who've actually got COVID. I mean, are they all coming through the test centres, or are there other ways in which people are now being diagnosed with COVID?
So I think we probably need Sarah to give a definitive answer here, but certainly it will be through the test centres, and through that we certainly in primary care, GPs are made aware of patients with positive tests as well, and the importance of that, in fact, it gives me an opportunity to mention something called the virtual COVID ward. And this is a ward that patients are kept in the community and have what's called a pulse oximeter, where they can regularly measure their oxygen levels, and they're monitored remotely by health professionals, and that acts as an early warning sign for when people's oxygen levels can dip, and if required, and get to hospital at an early stage. And the evidence has been really good in the sense that we've probably prevented some people from going to hospital where they may not need to go to hospital, but also when people really did need to get to hospital, they get there quicker, and the result is that they then stay in hospital for less time. So it's called the COVID virtual ward, and again in Gloucestershire we led the way in one of as a pilot, and it's been really effective. So GPs will get positive COVID tests, will check with the patients whether they want or need to go onto this COVID virtual ward, and then we monitor in that way. Thank you.
David, do you want to come back?
Yeah, I mean, that's very interesting. I mean, the follow-up would be, I mean, what evidence is there amongst younger people who obviously have had COVID but have never taken a test? Is that something that we're able to do I know it's a double negative, but are we able to do any work on that at all? Because I suspect that may be one of the ways in which it's now spreading.
Yes, again, I think I would defer to Sarah to answer this fully, but this is all part of the test and contact test and trace, and the recognition, as you implied, that there's a lot of asymptomatic spread, particularly in younger people. So it's really about adhering to the test and trace program and isolating where appropriate.
Okay, so a question from Helen Fenton. I think that's the last question actually.
Oh, hi, Andrew. Before getting elected as a district councillor, I was volunteering at my local COVID vaccination hub, and actually at that time I'd lost some paid work because of the pandemic and schools closing earlier in the year. So I was actually looking for paid work, but I ended up volunteering. But I'm still aware that the vaccination hubs are desperately short of volunteers to actually help facilitate these vaccination sessions, and I wondered kind of what is the value to the NHS of all this volunteering, and what is the long-term what is the long-term plan, given that volunteers like myself, their situations change? And also given that there's talk about us all needing boosters, maybe one, maybe two. I don't really know what the idea is about COVID boosters next winter. So this is like an ongoing problem into the future. I just wonder what the official thinking is on that.
Yes, thank you. I mean, again, well, thank you for volunteering. It's hugely appreciated on behalf of the system. Yeah, I mean, sustainability of the programme is clearly an issue, and we will still rely on volunteers. And we do have links nationally with kind of volunteer groups as well, and places like St John's Ambulance who are providing volunteers. So it's a question of coordinating and making sure we have enough people. But going forward, I think what we need, we're waiting for national guidance about what the autumn programme looks like. And what the key really for us is going to be whether you can give a flu jab at the same time as the COVID booster. And if you can, then that will make it much easier to run, because then obviously GP surgeons are very used to running a flu campaign, and you can run it alongside that. If you can't, then logistically it's going to be an issue for us and obviously the whole of the country. So we're just waiting for some trials nationally, which will determine whether you can double run vaccination program. So sorry.
No, I was going to say, could I just add something quickly to that? Would that be okay? So the other thing it might be worth just flagging as well is that in Gloucestershire we are pulling together the learning from what has been obviously an exceptional year through the pandemic and so on. Partly into something we've called our silver linings report, but also specifically into a volunteering strategy to both learn from the experience of volunteering over the last year and the incredible contributions that people have made, but working with our partners in the voluntary sector to develop a volunteering strategy for Gloucestershire, to both learn from and build into the future. So that volunteering strategy, I know it's not yet completed, but I think it would be certainly something maybe in the autumn that we could bring back and present and share here. And I think it is also true, as Andy said, that I think the pivotal thing would be around whether it turns out we can or can't deliver those COVID boosters alongside the flu campaign, which obviously the NHS is very well used to running. And would make a significant difference to us if those things are able to run together. But we're planning around various scenarios about how we can do this over the longer term. Yeah.
Can I come back in there, please, Andrew?
Sorry, I was on mute. Yeah, Helen, please come back. Thank you.
Yeah, I mean, I have a concern about the sustainability of using volunteers longer term to deliver a core health service. I mean, for myself, I had lost paid employment. I have lost a lot of income in the past 12 months, and I was willing to volunteer during the pandemic. That's an exceptional situation, and I have the available time. I no longer have the available time. My situation is changing. I think for many people, the immediacy of the pandemic, as that retreats, they're no longer going to be either available or willing to continue to volunteer for a statutory service, and that's my concern. I mean, prove me wrong if you like, but having worked in the voluntary sector over many years, I think delivering high quality services using a voluntary workforce is an uphill challenge. And I also think that it fails to get employed. It fails to create jobs for the local economy, which is what people need, particularly at this time as we start to come out of the pandemic. People need employment. People have lost work in all kinds of shapes and forms, and that's critical.
Helen, I think to reassure you, I'm not aware of any plans where a statutory service is delivered by a voluntary workforce, but we will absolutely bring that strategy back and share that in the autumn when that's complete. And you know, you're right, we've been in exceptional times, and volunteers have done amazing support work around those vaccination centres and those hubs, and we need to think about the model going forward and how that is sustainable. So I do agree with your point completely. Thank you.
So Helen, you raised some good questions. Thank you very much, and I'm sure that you'll raise them at future HOSC meetings, and we look forward to you doing that. Okay, so final word goes to Sarah Scott, who has now joined us. So Sarah, welcome to HOSC. This is a bit like deja vu, putting questions to you from me, without mentioning a bus. Sarah, the floor is yours.
Thanks, Andrew. Good afternoon, everybody. I'm Sarah Scott, Executive Director of Adult Social Care and Public Health. I'm sorry I couldn't join you at 10 o'clock this morning. I've agreed with Andrew that I would just deliver a short presentation to talk you through some of the data, the most up-to-date data we have around COVID, and I'm happy to take any questions on that data. I think Joe's going to upload the presentation for me. If we could go straight to slide 3, please, Joe.
Sarah, my CD viewer is not responding at the moment. If you carry on, I shall try to load. Okay, it's just gone down. So just can you ad-lib at the moment?
Right, I'll just fill. It's fine. So what we're about to show you is a presentation that we share quite often publicly. It goes to different scrutiny committees. We've taken it to the Health and Wellbeing Board. It's been shared with partners. I shared something very similar with Stroud District Council member induction, the meeting last night. So part of my team's role has been to try and understand the data. And in the beginning, we had slightly different feed of data into the council. So now we've got lots of intelligence around how COVID is affecting our county. For example, we have a list of every single person who has a confirmed case of COVID in the county, and so we can actively investigate those outbreaks and clusters. And we work very closely with PHE to do that. So what we're about to show you is the summary slide of this particular data set. And for example, the data we're going to show you today, there's normally a 5-day gap between when the data was generated and the day to day. That's to ensure that we've got all the cases that were confirmed via the PCR test, that lab confirmed gold standard test that we use to confirm cases. We've seen over the last few weeks an increase in cases. So our rate now for the county per 100,000 is 48.7 cases. So it is increasing, and certainly we've enjoyed a very low rate for the last few months. So that's 179 cases up on the previous 7 days. We've seen an increase across all 7 districts. In particular, our highest rate at the moment is in Gloucester, so that's got a case rate of 73.6. We're also seeing quite high rates in Tewkesbury and Cheltenham, so 66.3 and 66.2 respectively. 28.8 in the Forest, 25.8 in Stroud, and 21.1 in the Cotswolds. So overall, an increase everywhere. And just to reassure you, so we understand why these increases are happening. So we know where the cases are. We know if they've engaged with the NHS test and trace system. And we can then understand through the information that's available to us through the contact tracing service, are they linked to an outbreak? For example, we've had some outbreaks associated with some of the universities, some workplaces, some schools. And then we can understand with the information we've got how to make the links, and sometimes we find mini cluster just by finding what we call common exposures. Have they all been to the same pub, the same place, the same workplace? And my team, I should say, we work from 8 till 6, 7 days a week. So we've got a 7-day service and have had that since the beginning of the pandemic. So we are able to fulfill this service and do this work 7 days a week. I'll carry on filling, Joe. So on this particular slide, it also gives us information about deaths. And really sadly, we have had 1,099 deaths from COVID since the beginning of the pandemic, but we haven't had any deaths in the last couple of weeks, which clearly is really good news. No, any sign of? Shall I try and see if
my system's completely lost signal, so I'm trying to get it back. If you can keep talking.
It doesn't often work when I want to share. There's a bit of a glitch on my system, but I'm trying to do that now because otherwise I'm just talking at you, which probably isn't very.
And Sarah, we can circulate after the meeting, can't we, to the committee? Yeah.
So
keep trying.
Can you see it now? Can you see a presentation now? Yeah, I can see Joe nodding. Right, that's a relief.
We can. Hooray!
Right, okay, this is probably slightly more interesting for you then. So the gold box in the middle there has our rate that I've just described at 48.7. Underneath that, you can see the 14-day trend, so an increase on the last 7 days. I've just talked about the district rates here. So we can see down the middle in that amber and gold and green boxes, that's the latest 7-day data for the districts. What I would also say is that we've seen some quite huge percentage changes in the case numbers, and sometimes when we have relatively small numbers, for example in the Cotswolds, the numbers have gone from 15 to 19. So it's a difference of 4 cases, but the percentage increase looks quite scary. So it's always better to try and dig underneath the data and that initial headline statistic. So if we move on to the next slide, hopefully you're all seeing this. Because it's not quite fitting my screen. So this slide talks about the numbers of tests and results in our residents for that particular time period between the 3rd and the 9th of June. And we can see in the top right-hand corner, there's a graph there with the green line, which is our total number of tests, which has remained pretty static during this period. But the percentage of positive tests has increased, as you can see by that dashed pink line. And as we scroll down further, in the bottom, in the middle, you've got the tests by age group and gender. So we're still seeing the most number of tests carried out in the 40 to 59 age group, but we're seeing much higher rates in the younger age groups, particularly around the 20 to 24-year-olds. A fairly even rate of test uptake across the district, slightly lower in the Forest of Dean, but nothing we're particularly worried about. So the next slide, I'm assuming you're all seeing this, unless I can see a thumbs up, that's good. This talks about positive cases, so those that have been confirmed through what we call a PCR test in a laboratory. And you can see that we've got a slight increase in our cases there, going across this time period in that line graph in the top right-hand side. And at the bottom, cases by age and patient gender in the middle, and we can see there, so we're seeing an increase in the number of cases in 0 to 19-year-olds, which would play out because we're seeing cases in schools at the moment. But then that 20 to 39 age group, quite an increase in cases there, particularly that 20 to 24 age group. And that's the group we think primarily are out mixing and enjoying some of the freedoms that the lockdown, easing of the lockdown has brought with it. Bottom right-hand corner, cases rate by district, which you've seen in the initial slide. Now, the national data is released on what we call a medium super output area, or a middle super output area, which is basically bigger than a ward but smaller than a district. And we've got around 75 of these across the county, and on average, you get about 7,500 to 8,000 people living in what we call an MSOA. So they don't neatly fit to our local authority geography or our member divisional boundaries. So what we can see here is it's quite a confusing map because it's not the entire area of Gloucestershire. So basically, if the area is white, it means that there are no cases. So the darker the colour, the higher the prevalence. And so we can see some obviously around the Gloucester and Cheltenham area and in parts of Tewkesbury and Stroud that we are seeing some cases. And sometimes it's quite helpful just to have that visual representation to understand where the cases are.
So I've just managed to load everything up on a full screen. Would you like me to share?
I'm nearly at the end now, Joe. It's fine. I
So
think I've only got another slide to go.
Thank
It's
you.
all right, don't worry. The next slide is around deaths and death registrations, and thankfully we haven't had any deaths in the last few weeks, which is really, really good news. We saw most of our deaths in the first wave, and a pretty even split between community and hospital deaths. And in community, we would also include care homes. And that's the end of the presentation. So I'm very happy to take any questions on that. I'm aware it was a whistle-stop tour. I'll just stop sharing my screen.
Yeah, hi Sarah. Do we have any hands showing questions?
One second. Let's get rid of that.
No members? Oh, we've got one. Sorry, we're trying to work out who that is, Sarah, unless you can see before us.
I think it's David Drew.
Yes.
David, over to you.
Yeah, hiya, Sarah. Is there any clarity now, after yesterday's announcement, on events and larger numbers of people being able to congregate? I mean, we've had pilots, but clearly, you know, we will be starting, we're in the cricket season, we'll be starting rugby and football. I mean, is there any clarity on how that will be managed, even if it's allowed? I mean, who restricts numbers and decides on tests and the rest of it?
So I've not seen the output of those pilots. I know it's coming. So we had the national pilots, a range of different sporting and sort of music events, didn't we? Testing out the effectiveness of the different testing regimes, both PCR and lateral flow tests. So we have had some events, and each district has a safety advisory group. So we would need to link in with that safety advisory group. That's district led. We've been engaged in all of those groups. And then we would just have to we give advice based on each situation. We have had direct contact from some of the organisers of bigger events who are keen to engage with us, but I think we just have to await the guidance of the national pilots to see what the risk assessment is in terms of increasing numbers of people, and whether then we need to adhere to the guidance, because obviously there were some pilots where there was no social distancing and no masks at all, and then whether we can support that across the rest of the country.
Sorry, David, do you want to come back?
That's just very helpful. I mean, in other words, we don't really know yet, but for those organisations trying to make plans, it's a bit of a nightmare at the moment, because you're planning for a small number, a larger number, or no number at all.
Sure. Sorry, so we've got Councillor Stephen Hurst indicating with the questions for Sarah.
Thank you, Chair. I'd like to know your views, Sarah, on vaccination in schools, where lots of people get together.
So my team have been working closely with Marion Andrews-Evans and Helen Goody, who've been leading the vaccination programme for Gloucestershire, to discuss how best we should vaccinate. I think I caught the tail end of Andy's discussion, and a lot of it, I think, depends on whether we can give flu and COVID vaccinations at the same time. We've got a very strong school-based vaccination programme in Gloucestershire for a range of different conditions and diseases. So I think it does make sense to try and use the schools as much as possible. We've engaged some head teachers in this discussion, and I think compared to what they had to stand up at very short notice around lateral flow tests over the Christmas period, I think supporting another vaccination feels quite doable. I wouldn't wish to speak for head teachers, but we've had some really good engagement with a select group of them. So they're actively part of our planning process at the moment.
You think we shall be vaccinated in schools then, Sarah?
Well, it's been approved for ages 12 to 15, hasn't it? So I think that we're planning we're planning for that eventuality. I think we've actually, I'd have to look to the CCG for clarification, but I think we've yet to have confirmation we are actually being asked to do that, but we're drawing up plans in case we have to.
Great, thank you very much.
That's my understanding.
Thank you.
Stephen Andrews, Councillor.
Thank you very much. It's really going back to the question that David Drew raised to do with events. I attended virtually a local government association session on those mass events and the lessons that were starting to emerge. And it did seem to revolve around very much public health engagement with the SAGs, and also their view that was taken then upon testing beforehand, so people could turn up with some proof that they'd had a test, whether they'd been vaccinated, and other views of that sort seemed to be the things that needed to happen for events. And I just wonder whether, given that SAGs are in Gloucestershire put down to the districts, whether there is that strong connection that might be necessary with the public health function, because they're used to really looking at security from are the events things that can be properly policed and things of that sort, not looking at them as possibly becoming COVID hotspots.
Thank you. So just to reassure you, my team and I have been actively engaged with district colleagues throughout the pandemic. They've been an essential part of our local resilience for a response, our local health protection response. So we are attending the SAGs when invited, and there's an ongoing dialogue. We've used some of the COVID monies we've received to invest in additional environmental health staff and COVID marshals through the district councils to ensure that they've got sufficient capacity to respond. So absolutely, we are engaged. I think the role of the SAG is quite important to understand. So we've had a lot of discussions, for example, about the Still on the Road horse fair, and they're not permissive. The SAG does not decide whether an event should go ahead or not. Its role is to understand what the risks are and help to mitigate them. And there's a very important difference there. So yes, we're always happy to provide advice. I've not seen the full guidance that's come out of the of the national pilots. I know there has been some early learning shared, but we absolutely, I would see lateral flow testing being a part of that, but we have to understand the limitations of lateral flow tests. They're very good at telling you if you've got COVID, if you're highly infectious. They're not so good perhaps if you were a close contact of an infectious person yesterday. And then I think it's better to consider lateral flow tests as part of a complex toolkit of things we're using to combat COVID. Vaccination is another really important part. And one thing I didn't say in the update was about variants of concern. So you would have seen a lot about the Indian variant, now called Delta, in the news. We know we have easily over 100 cases of that in the county at the moment, and that's through the publicly available data that is published. I think it's every Friday morning now. And so we're just assuming that the cases are Delta variant, but the way to keep yourself safe is exactly the same, following the guidance around hands, face space, ventilation, regular testing with lateral flow tests and PCR tests if you're symptomatic, and also getting both doses of your vaccination.
Yes.
Thanks, Sarah. I see no other members indicating with any questions.
Andrew, it's Robert Vines here. I've had my virtual hand up for quite some while.
Oh, apologies, Rob, we missed that. Apologies. Go for it.
Yes, thank you very much, Sarah, for all the information, all the facts and figures. I'm sure most of us keep up to date with our daily input, so that's really, really good. But my question would be about long COVID. Do we capture any figures for that? I am aware the television presenter Kate Garraway's husband has been suffering for a very, very long time. He can't be the only one, and I have been told of other people who are suffering. And the fact that they haven't died within 28 days of being tested positive, they seem to have been sort of just gone off into the ether. Do we capture any figures? Do we know how many cases? Do we know what's happening with people who are continuing to suffer? Should we term it long COVID?
I can absolutely assure you that these people have not been forgotten. Absolutely not. I think probably Andy might be better placed to answer this question in terms of how we're recording and how we are supporting these people. But certainly there are some health services that are being planned and being put in place. So they're absolutely not been forgotten, I can assure you. I'll hand over to Andy.
Yeah, thanks, Sarah. Yeah, I mean, it's a good question, and we're certainly well placed in this county to manage people with long COVID. And we've got a clinic now set up across the county, which is multidisciplinary, and as I say, input from all health professionals across the county. And the entry would primarily be through the GP, so patients coming to the GP with long COVID type symptoms and then being referred into that service. But there's also still people who've been discharged from secondary care, having been quite ill, who are still followed up as well. So absolutely confident that people will not be missed or lost to the system. In terms of numbers, I haven't got them at the moment, but we can certainly get them to you for next time.
Thank you for that. So Rob Vines, are you okay with that? Do you wish to come back?
Yeah, I'm fine with that. Very helpful, and thank you for the answers.
That's really good. I think the last question this morning on this session is from Helen Fenton. Helen, are you able to put your question?
Yes, thank you. Just to follow up on the long COVID, I actually work with a counselling client who is a young woman who's virtually disabled by long COVID, which she had in March 2020. And she's repeatedly contacted her GP, one of Scrutiny practices, around this issue. She has been repeatedly told that there's no service to refer her to for support with long COVID. So I'm not so sure that things are working well yet. I don't know where the discrepancy is, but that's not I know that's an anecdotal experience rather than anything bigger, but I wonder if, I don't know what we can pick up from this, because clearly things aren't working well across the board yet.
Sure. Obviously, we can't pick up individual cases, Helen. But Andy,
I appreciate that, but I think it's indicative.
You did qualify your remark. But Andy,
Yeah.
in general principles, can you pick that up, please?
Well, general principle is certainly that, as I said, we do have a clinic. It is out there, and we've advertised it through our normal communication channels. Clearly, it seems we have to continue advertising it. But if you'd like to contact me, Helen, out of the meeting about which practice is involved, I can certainly look into this.
Okay, thank you very much.
Yeah, thank you very much. That's really helpful. Thank you. Thank you, Helen, for raising that. I think...
Sarah want to come back.
So Sarah Scott.
Hand up.
Thank you, Andrew. Just really quickly to say that we send out a weekly email to all elected members via the 7 Democratic Services teams. So each week you'll get a short update from my team. There's also a huge amount of information on our website that might help with queries in your post bag. And we also have a help desk email as well in case you need some extra support. And finally, we've produced quite a lengthy report that describes our work on COVID across the system for the adult social care and community scrutiny next week. And I know Joe's going to share that with you. It's quite long, but the idea being for the induction programme, induction session for that particular scrutiny committee, we would go into a bit more detail, but we thought it might be helpful for you to see it as well.
So thanks, Joe. Thanks, Sarah, and thank you, Dr. Seymour.
My apologies, Sarah, for the technical hitch. I do apologise.
Can I just thank Sarah and Andy Seymour for finding time to come and talk to us today. Appreciate you're incredibly busy. Thank you so much for what you're doing for the people of Gloucestershire, and just look forward to seeing you at our next HOSC meeting, or in Sarah's case on the telly. Okay, sorry. We're now going to take a 5-minute break before we tackle Fit for the Future. So, Joe, just remind me, my watch says it's coming up to 2:30.
If we say 25 to?
25 to 2, 25 to 1, sorry. No, 25 to 1 to be very clear. See you guys in 5 minutes, thank you.
If recording, if you could turn your microphones and your videos off while we have the break, thank you.
Okay, I think, are we ready to start, Joe?
I'm ready to start, yeah.
Sarah?
Yep, okay.
Okay, so we're moving on to Joe's beat me to it, Fit for the Future. Who's speaking to that one?
Helen.
Yeah.
Actually, I'll make a start on this one.
Fantastic.
Yeah, hi. Simon, Simon Lansley from the Acute Hospital.
So can I, just before we kick off, can I just remind everybody that we've had all the slides, which we've read, and thank you again for sending them over earlier. Earlier last week, I meant, not today, obviously. That helps us a lot, and it helps us to concentrate our minds on questions that might arise and all the rest of it. So can you just highlight 1 or 2 key points? Well, I know there are more than 1 or 2, but the key points that you want to get across without necessarily going through each page, if that makes sense, please. And then we'll invite questions.
Yeah, that's fine.
Thank you.
Yeah. If I just come off the slides then, and just assume people have had a chance to look through those.
Yeah,
so I suppose a couple of key messages we wanted to get across. A couple of key messages, recognising we have some new members, is first of all some assurance that HOSC played a key role in the development of this programme. So over the last 2 years, 10 reports and presentations have come through HOSC to share as the programme's developed. So as we've gone from long listing to medium listing to short listing, and recognising the HOSC voice is a key part of that. And also in the decisions we've made. So, for example, to go out to public consultation, that we brought that through the committee as well to ask for support in that area. Second point I'd make is around the kind of the vision for Fit for the Future. So it's not necessarily about this. Sometimes we use this language hot and cold. One site's the hot site and one site's the cold site. This is a different vision to that. So it's built around a greater separation of emergency and planned care, so more emergency activity happening on the Gloucestershire Royal site, and more planned care and oncology care happening at the Cheltenham General site. But really important for members to understand it's not a purist model here. So we're not saying all emergency on one site and all planned care on the other side. And you see that through our commitment to Cheltenham Accident Emergency Department, AN unit, for example, which will continue in its current form and is part of a phased reintroduction now. So it's back to its daytime operating hours, and then on the 30th of June, the overnight services reopen as well. So commitment to Cheltenham A&E, but also a commitment to Cheltenham Critical Care Unit. So part of the vision is to continue some complex elective operating on that site. So things like urology and gynae oncology, for example. And to do that, we need a fully functioning critical care unit. So a bit of reassurance, as I say, it's not a purist model. It's not all emergency at one and all planned care at the other. But it is built around the principles of the long-term plan, which the separation of planned care and emergency care is better for patients, better for staff. And the reason for that is, if you imagine a really busy district general hospital, peaks and troughs in emergency activity, and when that happens, when you get a peak, you're all competing for the same staff, the same beds, the same theatre space, and the same diagnostic equipment. So if we can separate off as much planned care activity as possible, so things like elective hips, having your hip replaced, your knee replaced, or your complex general surgery, if we can take that to a separate site, it means more reliable access to those services, so you're less likely to have your operation cancelled. And that's the principles of the long-term plan, and that's what we've applied here in Gloucestershire. So third point I'd make then, Chair, is around engagement. So we didn't sit in a dark room and come up with these plans and then come and tell everyone this is the right thing to do. So a long engagement process that has run back into 2017. We had some engagement activity where we went through the shortlisting, again, getting feedback from patients and citizens and interest groups. And then we came to our final shortlist, and that was what was approved through the CCG governing body on the 18th of March. And that whole process that we went through, and there was someone called the Consultation Institute, which provided an external independent view of the process we'd taken, and we got awarded good practice for the approach we'd taken, recognising how we'd responded to the pandemic and altered our consultation process to take account for that. And then finally, the last one I'd make is around implementation. So the changes, there were 7 reconfigurations that we went through, which were on the slides that we provided. Sometimes there's an assertion, well, you've gone through the consultation and now you're going to jump straight into implementation. And actually, either of the sites can't cope. There's not enough, ward capacity on one site or theatre capacity on the other. So this is a phased implementation. So over the next 2 years, we will implement these changes according to when estate comes online, when the new equipment becomes available, and when we've recruited and trained up some staff to support the change as well. So that's the third bit I wanted to get across, is this is not an overnight implementation. It's a phased implementation over the next 18 months, 2 years. So I'll pause there, Chair, and that might prompt a few questions.
Yeah, thank you. Looking at my colleague Joe over the table, we have one hand. I can't see who it is.
Councillor Stephen Andrews.
Stephen Andrews, Councillor.
Thank you very much. Thank you very much for that quick summary. The last meeting of the HOSC, a number of points were raised to be highlighted going forward with the HOSC. I think some of those might actually be covered in your implication of what you've just said about a phased implementation. And of course, that phasing is not yet clear. And I just wonder, first of all, whether we can have circulated a copy of the points that were raised from the last meeting to make sure that we don't lose them. But also whether we are going to receive the phased plan, as it were, for comment.
So if I respond to point 2, and then Joe might want to pick up on point 1. So yeah, so point 2, absolutely. I think the next meeting we've got a more detailed session on Fit for the Future and some of the temporary changes. So absolutely, Stephen, I'll bring the latest. These things change, don't they? But I'll bring the latest implementation program to that meeting. And Joe, I don't know whether you want to respond to the first point about the list of questions.
I can. Stephen, Councillor Andrews was at the meeting on the 22nd of March. The minutes of that meeting are on the website, published on the GCC website, which it goes into great detail of the issues raised and the outcomes of that meeting. The outcome of the meeting was that the issues, the concerns that were raised would be taken away and would be addressed at the next meeting on the 13th of July under approval of the minutes, and I would think in a more in-depth briefing note on Fit for the Future. We will certainly be covering the concerns of the committee, which Becky, I'm not sure if you want to come in, but as far as I'm concerned, all of the issues and concerns have been now addressed and closed, but we will be feeding back that information to the committee at its first proper meeting. But if you did want to have a look, and I will happy to provide a summary sheet of the issues raised, but you might want to just also check, and for new members, check the minutes of the meeting on the 22nd of March and earlier meetings. A lot of the issues have been covered in a significant amount of detail at meetings throughout the latter end of 2020 and into 2021. So it might be useful for members. It is quite a lot of reading, but you might want to go back and look at the minutes of previous meetings. Becky, did you want to add anything there?
I think the only other thing I was going to add is that in the presentation that Simon's just summarised, there are links to some of the longer documents that are associated with Fit for the Future, and a lot of the responses that we gave to previous HOSC meetings with regards to some of the detail that some members were interested in were all included in something called the Decision Making Business Case, which is a very detailed document, but you have got the links to it. And I do have printed copies of it as well. If people would prefer to read it in a printed copy, I can send those to you if you give me your postal addresses. As Joe says, a lot of the questions came up several times, and there were several times that we answered the questions. And as I say, there's a lot of detail in the decision-making business case, and indeed the incredibly excellent output of consultation report, which is very long, but it does summarise all of the feedback that we received from the public, which was very, very well received and was taken into account when the decisions were made back in March.
And could I just add something quickly as well, Joe? That'd be okay. Yeah, just to say, just sorry, I think you're on mute, but I think you're nodding. Partly Becky's covered it, but regarding the implementation plan as well, we will obviously bring back a summary, and I know not everyone has time to go through our quite dense documents, but there is quite a lot of information provided on that in the decision-making business case as well. And all of that is available in the public domain and online. So I think Simon's absolutely right. We could provide the latest version and an update and so on. But if anyone obviously can't wait for our latest instalment next time, then we did provide an implementation section in that document. It's on our website. People are very able to look at that in the interim period, and we've provided the links if anyone would want to, or Becky can post out a hard copy if that's easier.
So Stephen, I was at that meeting too, and it got quite. I got very confused as to what had been addressed and what hadn't. I'm very clear that on our first HOSC meeting, which is the one quite early, well, middle of July, I'm going to try and make it as clear as possible what information and what issues have been resolved already. And with the committee's member, particularly those who were there at that special emergency meeting, those issues which still need to be signed off or cleared, whatever expression we use, by the CCG and the Hospitals Trust. I'm so keen not to go over old ground, but I'm also very keen to ensure that the points that you were making just now, and which others have, which remain open, are addressed, so that once and for all we can get to a point with Fit for the Future where we think HOSC and all of the health trusts are on the same page. And I don't want to use the phrase "it will take as long as it needs," because that's almost an invitation for us to be there all day. But I am determined to devote the time required, if I can phrase it that way, to ensure that when we leave that meeting, we are all satisfied where we are and on the same page, HOSC and our health colleagues. I hope that's helpful, Stephen, and gives you that reassurance.
No, thank you very much. I'm fine with that. I just, rather like yourself, feel that there needs to be a formal line drawn.
I think that's keen. I think that's important. I'm keen to working with Joe and the colleagues here at Shire Hall to achieve that. But I'm also very keen not to go over ground.
No, I'd agree with that.
I mean, there is so much that's been resolved. When I went, Becky really was helpful in getting me up to speed and showing what had been signed off. And I so don't want that to happen again, Stephen. I'm really keen that we move forward. And by the way, just on etiquette, I will ask all members when I talk to them, are you okay for me to address you by your first name, or do you insist on being called councillor? Not just
No, I'm quite happy.
Okay, that's really helpful. Thank you. Me too, by the way. So on Fit for the Future, are we saying that we're okay with no questions for Paul and we can leave it until the July HOSC meeting
Entirely
to
up to
pursue
you.
it?
We've got two people with raised hands.
Sorry, I missed that on the screen.
We've got Councillor Stephen Hurst and Dilys Barrow.
Sorry, so Stephen Hurst and then Dilys.
Right, thanks very much, and thanks for that clarification, because I did want to ask more about implementation. I wonder if just briefly I could ask, in the immediate future, as it were, what situation is with sort of case numbers of COVID and possible more people coming into hospital, etc. What the situation is going to be, going forward in the short term. Is there a lot of flexibility between what we're doing, when the A&Es, particularly in Cheltenham in my case, is going to be open, etc. Just some sort of idea what you have in mind if cases were to go up and things were to sort of go downhill a little bit again. Thank you.
That's a fair question, a good question. So who's going to take that one, please?
I'm happy to take that one, Andrew, if it's helpful. Thank you for the question. As I'm sure you imagine, we all hope we won't find ourselves in that place, but as you'd expect, we are planning for such a scenario. You'd be aware that Cheltenham A&E was restored to its pre-pandemic state during the day last week, and we will be reopening the full service, so that includes the minor injuries unit, overnight from the 30th of June. One of the positive things about Fit for the Future was it did allow us, and indeed the timing of that and pandemic, it did allow us to test some of the things that we were proposing as part of Fit for the Future during the pandemic, and we very much designed our services with the possible scenario of a future pandemic, be that COVID or anything else. So one of the great opportunities, and I think HOSC was really helpful and really clear in its expectations that whatever we do, we should make sure that we've learned from the pandemic for the future, and that our changes have a future surge of this or any other pandemic in mind. So for Dilys, I'm confident that what we have designed, what we're planning, future-proofs us for the things that we can foresee, future-proofs us for a third wave, and that all the learning that we could possibly extract from the pandemic we have done, and therefore any future pandemic would be handled with all of that learning in mind. By way of a very contemporary update, and we do just have 3 patients in our hospitals this morning. You'll know that we were at hundreds at the peak of the pandemic. The patients that are being admitted are largely, with the exception of just one so far, those that have not been vaccinated or indeed not vaccinated at all. So again, the picture that we're hearing nationally about the vaccination programme having a positive impact on even the Delta variant is holding steady in Gloucestershire as well. And the very small numbers that are being admitted are tending to be less unwell than they were, and they're staying with us for shorter periods of time. So even if we were to see some larger numbers, and I don't think they'll be very large, but even if we see some larger numbers, then the impact on the NHS, I think we can safely assume, will be much less than it was in the first and second wave. So I hope that's reassuring. Obviously, there's some crystal ball gazing in there, and I hope I don't live to regret those words of confidence. But as Andy's alluded to, we are doing really, really well on vaccination coverage. The residual risk we have to manage is that we know from some of the national things, and particularly what's going on in the Northwest, that some of the younger members of our population are not rushing to vaccination in quite the way that some of our older populations did. So we do need to keep working really hard on the importance of vaccination for those that are under 30, where, as I said, some of the take-up's not been as strong as it was in the older age groups.
Thanks, Deborah. So, Dilys, do you want to come back?
No, thank you very much for that. That's a little bit more reassuring. Thank you.
Okay, that's good. Thank you. So we've got Stephen Hurst and then Stephen Andrews. Stephen Hurst.
Thank you, Chair. The more I read Fit for the Future, the more I realise that what we're looking at is a collection of centres of excellence. We have the the stroke treatment centre at Dursley, which is working very, very well. And am I looking at Fit for the Future too simply by saying what it is a number of centres of excellence in different buildings? Thank you.
Thanks, Stephen.
Yeah, I'll respond. Yeah, so
Yeah.
you're right, that's what we're trying to establish, and we already have some. So we're kind of building on that. So our oncology unit at Cheltenham General, for example, is an existing centres of excellence. That's how others would describe it. So it's building on that that model for other specialties. Clearly, we won't be a centre of excellence for everything, because there will still remain some tertiary pathways to some of the bigger hospitals, say in Bristol and Oxford. But where we can treat Gloucestershire patients in Gloucestershire, that's what we're trying to do. Yep.
Thank you, Paul.
Thank you.
So Stephen Andrews. Sorry, I beg your pardon. Stephen Andrews.
Thank you very much. If I can just pick up a point that Deborah made, and that is to do with how things seem to be going well as far as the hospitals are concerned. I get the view that things are not necessarily going as well based upon the number of ambulances that are currently regularly stacking up outside of A&E. This isn't a function of urgent care or emergency care. It appears to be a function of the way that the hospitals are able to absorb those patients. Because, of course, there is a knock-on effect then in terms of the unavailability of ambulances, because they're looking after patients outside of A&E. And perhaps this is something we can explore at our next meeting.
Thank you, Stephen. Sorry, Chair. Go on. I was gonna respond, but you haven't invited me to.
Sorry, go for it, Deborah. I apologise.
No worries. Me jumping in, but just enthusiasm, Stephen. You're quite right to describe the things that you have. Certainly back in March, we found ourselves in a very difficult place, and our ambulance handover delays were some of the most significant in the southwest. Very positively, since then, we have acquired some additional temporary accommodation, which has enabled us to significantly extend the footprint of our A&E at Gloucestershire Royal. And what I'll be very happy to describe next time in more detail is the significant improvements we've seen. So we've gone from being one of the poorest performers in relation to ambulance handover delays to being one of the best. In fact, over the weekend it was incredibly busy. I think our crews lost just 4 hours to the road, compared to tens of hours in other parts of the southwest. So some huge improvements in the last 2 months from where we were, and we'll be really happy to describe the things that we've done and how we've achieved that next time.
Great.
That's really good news.
I look forward to seeing those statistics, because I've actually been outside of the A&E last week when we had up to half a dozen ambulances stacked up outside.
And I, again, because I do absolutely will provide those. We can always point, and I can point to 1 or 2 days. If I look at the themes, if I look at the data week by week over that 8-week period, I'm very confident I'll be able to show you a significant improvement. In fact, I know from your other world that you've got contacts within SWAST. I think if you talk to any senior member of SWAST, and perhaps again they might be at the next HOS, then they would corroborate what I'm describing about the improvements. But there are days, for example, yesterday we had more attendances at our A&E than I can ever remember pre-pandemic in 5 years. 511 people, that was 50% more people came out to an A&E in the county yesterday than we have seen in our averages over the last 6 months. Now, none of us fully understand that. Helen was describing what the forest felt like yesterday in terms of tourists and visitors and the like. And so I'm absolutely happy to say that when we get those sorts of numbers, when 50% more people come, we're used to and we're staffed for, then I'm afraid we will get scenarios of queuing and waiting as you describe.
Thank you.
Thanks, Deborah, for that. That was really helpful. In your reports, Deborah, future reports, I'm sure you do it anyway, if we could have all the positive news as well. I mean, HOSC isn't here just to look at things where we're not meeting targets. It's also to hear about the work that we were doing, for example, on vaccinations, where we really are trailblazing. And I'm really keen to hear about that work and ensure that we publicise it and give you all guys.
And Andrew, it is your heart. I can't just miss the opportunity with that plug there from you. Is just a note, because again we don't meet for a little while, is that Gloucestershire, the whole system, was the top performing, so ranked #1 in the whole of England for our lung cancer standards performance. So the best performing trust in England for the period 2021. So for that whole 12 months, the best performing trust in England for lung cancer performance. And indeed, I think the only trust in the South West, I'm pretty confident to say that because I chair the South West Cancer Alliance, the only trust in the South West to be delivering all 8 cancer waiting time standards. So you're right to draw out those very positive things as well. Our Achilles heel, and as you know, Stephen, it is A&E performance, and we couldn't be more focused on it, but it is a huge challenge for us.
Sorry, Deborah, you broke up a little bit there. Just to make sure that I heard you correctly, did you say that we were, or you weren't, we can't take the credit, that the trust was the top performing trust in the country for lung cancer rates or targets?
Yes, for the 62 waiting time standards, so that's the period from when your GP refers to you to when you're treated. And it's the indexed measure of lung cancer performance, because you will know yourself, Andrew, that timely diagnosis, timely treatment is how we get better outcomes, particularly for this cancer, for lung cancer. So yes, #1 in the whole country.
So I hope people don't suspect that we've set this up deliberately between us. But,
we did.
No, because we obviously haven't, but in the next couple of weeks, it will be six years since I got on the lung cancer pathway and ended up having a little stay in Bristol Royal Infirmary for 4 nights, and then quite a few sessions with you guys over in Cheltenham. So, you know, on a personal level, I'm not surprised you are where you are. Thank you. I don't know if I should have declared an interest at the beginning of the meeting.
We're in an induction.
So, in terms of coming back to Fit for the Future, just really quickly, Deborah, on cancer, and I think it was in relation to lung cancer, it was mentioned at the last HOSC that there appeared to be a reluctance of some people, some members of the public, to present to their GP because of fear. That's not the right word, fear or reluctance to have to come into hospital, to have possible serious illnesses, conditions checked out. Does that still exist? And I think you were telling us, or somebody was telling us, that we had anticipated more numbers of people presenting with different cancers than were coming through, yes, which indicated there was a reluctance to come in. Has that been addressed? Is that still the same situation now?
So, thankfully, demand is back up to pre-pandemic levels in relation to cancer, which is positive. Primary care has never been busier, so they are certainly seeing a degree of catch-up. So people that did stay away during the pandemic are now presenting, and again, that's some of the people that are coming to A&E. Again, we did better than many systems. I think our service changes, the way we organised ourselves, did give people some confidence to keep coming to services, for example, in Cheltenham. So we saw around 85% of the people we would normally see during the pandemic period. So that 15%, I don't think they've all come back. And if we look at what you're referring to, Andrew, so for example, lung cancer detection rates, the number of lung cancers we found last year, it is lower than is typical, and sufficiently lower for us to think that there are some cases of lung cancer yet to be identified and found. It's a very difficult cancer to detect without X-ray and imaging. So we are picking some of that up in later stages in our A&E. So that's one of the really sad stories, I think, from the pandemic, is that there are some patients who will present later with their cancer than they would have done, and they won't have such a good outcome, unfortunately. Paul Roberts, that you heard from earlier, is leading our work on inequalities to look at how do we need to change the way we deliver our services to give us a better chance of finding the people that didn't come out. We know there were certain groups, we know there were certain geographies where referral rates were lower, and so doing some really targeted work to go out and encourage those people to come back and look for those people that we may have missed first time around.
That's really helpful, and I'm sure the message goes out all the time to people saying, don't delay, just come in and see us, talk to us.
It does.
That has to be the right message. Thanks so much for that. We have one more hand, Joe, if you can help me out, please.
Councillor Stephen Hurst, did you want to come back, or
is that an old hand? Is that an old hand, Stephen?
Oops, I think you're muted. I don't think you want to come back.
Experience of the fine work that is done in Cheltenham with particularly breast cancer, where my wife suffered about eight months treatment, and it is fantastic. And people should not be frightened to go into hospital, see GP, because that's the only way you'll get sorted.
Thanks, Stephen. It's a message we have to keep getting out to people. Joe, help me out. I see no more hands.
No, I don't know if Simon, do you want to come back just to close that down, or are we covered there?
I think we're good. Yeah, we'll look forward to the session in July. We'll get into a bit more detail. Yeah.
So I think wrapping this one up. Thank you, Simon, for your presentation, and I think that the July HOSC will have this fit for future and the issues that trail over from our March meeting as a serious item. Not that anything we've discussed this morning hasn't been serious, but a major item, I guess, is what I should have said. Does that make sense? We really need to, Stephen Andrews was reminding us, to wrap this up, and as I tried to put it, to ensure we're all on the same page going forward, so it doesn't keep coming to HOSC again and again and again. That is just not good use of anyone's time at all, or resources. So hopefully on that positive note and the contribution from Deborah, we can wrap looking at my agenda, fit for the future up, if that's okay, ladies and gentlemen. Getting a nod of approval here from my minder here, Joe. So yeah, that's okay. So it takes us on to committee work planning. Can I suggest, members of HOSC, that we think about any possible items that the committee could look at over the next 12 months, think about that over the next week or two, and feed them into Joe and I, or Joe or I, and we can put them on the agenda for our March meeting to think about areas of work where we could add some value. I don't see us taking on board everything that's suggested to us, and I might circulate all members of the County Council asking them for ideas too. Does that make sense? Has anybody got any questions on that? I would rather, as elected members, we find our own work to look at and to scrutinise, and not having handed to us by well-intentioned people either here at the Shire Hall or in the health service. Does that make sense? Hopefully I put that as tactfully as I could.
I think from our recent scrutiny session at Shire Hall, basically it encouraged scrutiny members to look at drawing up a long-term or an annual programme of work. That I think that maybe we might have key priorities of work that are sort of fixed throughout the year, but it needs to be flexible enough for the committee, as Andrew's just suggested, flexible enough to accommodate anything that is urgent or short-term issues. So we will develop, and I think this is an item for the July meeting, an annual programme of work, that there will be certain items that are being prioritised and suggested to us as key items, and then flexible enough to accommodate any suggestions that you put to the chair at various meetings. I think that would be
sure.
useful.
I mean, here's my second fiver going to the cancer focused charity over at Cheltenham General Hospital. So when I chaired HOSC before, we had a inter-authority, cross-local authority scrutiny committee looking at the performance of the South West Ambulance Trust. So that was a major piece of work. We had Bristol on board, Bath and North East Somerset, and representatives from this scrutiny committee looking at the performance and work of the Ambulance Trust, because it covered a much wider region than just Gloucestershire. So there's another example where we could think outside the box and do work with other local authorities on issues which were of concern to us here in Gloucester. So I just chucked that in, and I think we can almost wrap the meeting up now, and thanks everybody for their time. Just on question item 8, I think, I'm pretty sure, Joe, we didn't get any questions come in which required an answer, which weren't raised at the meeting.
No, I think as Chair, Andrew was keen prior to each meeting to seek any topics or questions that the members might want to submit before the meeting. So I think that's an intention going forward, isn't it, Andrew, that you will ask for items or questions from members so that we can raise them at meetings.
Sure, thanks Joe, thanks for reminding me. The idea there was to get members' questions that they were saving for HOSC in before HOSC, so we could get them answered before the HOSC actually met, and that enabled us, gave us more time at the meeting to take questions which were arising during that particular debate, rather than, and you know, I think it would be wrong for members to feel they had to wait another couple of months before they could get an answer to their question. Don't bombard us and get us snowed under, but you know, just let us have the questions as and when you think of them, if that makes sense. Okay, getting some nods of approval there. It's coming up to 1:10. That's been a long session. I don't see any other hands up there. Joe, if you can help me out.
No more hands raised. Next meeting, 13th of July.
Everybody get that? 13th of July, 10 o'clock. Is that still virtual in this?
At the moment, yes.
Okay.
At the moment.
Okay. Okay, Stephen and Andrews, you looked as if you were about to say something. I'll give you the last word.
Sorry, it was just a surprise that it's still a virtual meeting.
We're just waiting. I think, as you can imagine, with the sort of current situation and advice coming from Westminster, we're just waiting to see how things progress. As soon as we have any updates, then I will confirm whether it's going to be a virtual or a physical meeting. At the moment, it's an unknown, so we will have to wait and see on this one.
Okay, I'm afraid that's the best you're going to get, Stephen. At the moment, sorry. Okay, so I'm going to wrap it up. Can I just thank everybody for their patience in getting through this long induction session. Thank you for the questions. Thank you for the good-natured way we've run this meeting. Hopefully it's come across as good-natured anyway. It certainly has sat here in Shire Hall. And I look forward to seeing everybody in next Wednesday in July. I'm going to make sure I get a back screen which shows some beautiful parts of Gloucester so that I can promote Gloucester in the same way that Stephen's promoting Ledgley. Okay, thanks everybody.
Thank you.
Signing off. Okay, thank you. Bye-bye.